सेकंड हाँ आता आता
कर. Good afternoon, everybody. We know that knowledge is light, and on behalf of ICOG, FOGSI President Dr. Rishikesh Pai, Secretary Madhuri Patel, and ICOG Chairperson Dr. Lakshmi Shrikande, and ICOG Vice Chairperson Dr. Parag Vinnivale. I welcome you all to this ICOG Masterclass, and this is first of its kind. And today we would discuss on the polycystic ovary syndrome. What you see is not what you always get. So I would now request Dr. Rishikesh Pai, President of FOGSI, to say a few words. He has been the Secretary General of FOGSI for the year 2015-17. He is the member of the BOD as the Board of Directors of International Federation of Fertility Societies, founder, chairman, and chairman of the Indian Special Interest Group of American Science Assisted Reproduction. He is the administrator for the International FOGSI Manyata Project. He has been the past president of Mumbai OBGYN Society, IAG, as well as Indian Society for Assisted Reproduction. He is the director of Bloom IVF centers, which are 9 all over the country, and is recipient of several awards like the Rashtriya Ekta, the IMA Best Doctor Award, the Navshakti Newspaper Award, Jai Hind College Alumni, the RK Trust, the Mediscape Mediscape India National Award, Lions International Gold Award, as well as the
list is very long.
I think, you know, basically, I think
he has,
anyway.
He has several publications to his credit.
Welcome, Rishikesh.
Thank you, Madhuri. Thank you, Dr. Lakshmi, for inviting me here for this program. Actually, I've just landed in Ranchi for the first time in my life. And, you know, I'm doing this yatra, which is now on the 5th week. And, you know, the last week is going to be the, when it will end in Calcutta, you know, the Durgapur and the Burdwan and Calcutta. So, in fact, you know, I've come to know the geography of the country because, you know, it's such a vast country. So, this yatra not only taught me a lot of new things, and I realized how vast the country is. Just like the knowledge is vast, I also realized how big the country is. And the funny part is that a lot of these societies I never visited in my life. I've become the president of FOGSI without visiting these societies, which is not a good thing to do. But I've realized that it's very difficult to reach so many societies, 263 societies. But it's a
Hello.
I think he got disconnected.
Yeah, he will log in again. Yeah. He's used to log in from the airports now.
Rishikesh, can you log in again? Shall I call him?
I think so. Yeah, he's here. Madhuri, don't call because he's on mobile. Yeah. Rishikesh, unmute yourself, please.
I said that I'm very happy that you are doing the PCOS part. So what it gave me an understanding that there's a lot to be done for the country. There's a lot of equity that needs to be done. And at least one part of our profession is that the guy, you know, we are by doing academic activity, at least we are equalizing one part of it. That is the knowledge part of it. But let us hope that we can also equalize the social part of it, our social commitment. So I would like to thank all of you. There's a lot of stalwarts that are there. Madhuri Patel, who is my classmate and a very intelligent, Dr. Parag Vinnivale, Dr. Madhuri Patel, who is our Secretary General, and Dr. Ashok, he is our Secretary of ICOG, Pratap Kumar, the great professor, I can see him also in so there are many people, and I wish you the very best. And I know that you are always there with me in this. When I go there today to the Ranchi Society, I'm sure they are waiting for me. You know, it's not only me, but all of you who is going there to meet them. So wish you the very best for everything. Thank you.
Thank you very much, Rishikesh, for that thing. And now I would request Dr. Madhuri Patel, who is a Secretary General of FOGSI, to say a few words. She has been the Joint Secretary of FOGSI in the year 2009. She's a former committee member of the FIGO preterm birth. She's an associate editor for the Journal of Obstetrics and Gynecology of India. She's the honorary clinical associate at the Wadia Hospital, Parel, Mumbai, honorary consultant at the Police Hospital, Mumbai, and she is visiting consultant at several other hospitals. She's been the former professor and HOD at the ESIC PGI MSR, Mumbai, former associate professor at the Grant Medical College, Mumbai, and she has been awarded the MOX Mrs. Shailaja and Mr. Narayan Pandit Award for the year 2019-20. She's delivered several lectures and keynote addresses, and she has several publications to her credit. Dr. Madhuri Patel, please.
Yeah. Thank you, Dr. Madhuri. And I must say, Madhuri Patil and Madhuri Patel, we share the common name, and also some people call me only Patil, not the Patel. As Parag always corrects me that I am Binewala, not Binewale. So I have to also correct. I am Madhuri Patel. So thank you, Madhuri, for your kind and generous words. And respected our President, Dr. Rishikesh Pai. Then ICOG Chair, Dr. Lakshmi Srikhande, Dr. Parag Binewale, Dr. Ashok Kumar, and Dr. Madhuri Patil as a convener, and all the other, teachers, they are here, and I'm really, congratulating Lakshmi and the team and Dr. Madhuri Patil for the most apt PCOS, which is very, very common. We see every day we face, patient not, if I have a patient, suppose I have 20 patients, I have most of them are 6 to 7 patients are of PCOS. So it is that common, and we all have experience, and that's why we have to know in detail, as the topic is given that PCOS, how to exclude the other causes, and then you come to the diagnosis of PCOS, or vice versa. So it is the most apt topic, and this is the first masterclass Dr. Lakshmi told me. So I'm wishing all of you best luck. I will not take more time, and best luck for your these masterclasses. Thank you very much for inviting me over here.
Thank you, Dr. Madhuri Patel. Thank you.
Yeah, and now we have
only one line, Madhuri. For me, only one line.
Yeah, we have none other than Dr. Lakshmi Srikhande, who is the chairperson of ICOG, and she's a medical director at the Srikhande Fertility Clinic, Nagpur, Maharashtra. She's recipient of several awards and has several chapters and publications to her credit. And she's delivered several orations and keynote addresses, and has been invited as a speaker at several places.
Thank you. Thank you so much, Dr. Madhuri Patil. And in fact, I am grateful to you because you agreed to be convener for this masterclass, and your selection of topic and speakers is simply commendable. So thank you so much on behalf of ICOG. And as ICOG chair, I would like to welcome our FOGSI ICOG president, Dr. Rishikesh Pai, our FOGSI Secretary General, Dr. Madhuri Patel, ICOG Vice Chair, Dr. Parag, ICOG Secretary, Dr. Ashok, Convener, Dr. Madhuri Patil, and all the eminent speakers, Dr. Pratap Kumar, Dr. Sharvil, Dr. Pankush is speaking in place of Dr. Neena, Dr. Padmarekha, and Dr. S. Krishna Kumar. So without wasting much time, Dr. Madhuri Patil is the best person to tell you her concept behind this PCOS masterclass. And in my tenure, I have planned total 12 masterclass, 4 on infertility, 4 on obstetrics, and 4 on gynecology. So next time, Dr. N. Palaniappan will be conducting a masterclass on an obstetric topic. So I urge you all to log into these masterclasses, and I hand over back to Dr. Madhuri for further proceedings. Dr. Madhuri Patil, yes.
So we also have with us Dr.
Parag.
Parag Vinniwale, who is the Vice Chairperson of ICOG. He's a senior consultant.
Madhuri, thank you. That's enough.
And he's a PG teacher. He's been the secretary of ICOG for the last 2 years. And he has also edited several books and he's a key speaker at several conferences. And we have Dr. Ashok Kumar, who is the secretary of ICOG for the year 2021-22. He's the editorial board member of Indian Journal of Medical Research and Archives of Gynecology and Obstetrics, and his keen interest is in maternal health. He has several research papers to his credit and has edited and written several chapters. So why did I choose this topic? So we know that PCOS basically is a complex clinical syndrome, and we know that it is the multi-gene environmental interaction which results in hormonal changes, and all these hormonal changes are basically exaggerated by obesity. And the main two abnormalities, the hormonal abnormalities seen as increase in the androgen and insulin levels, which are associated either with hirsutism or acne, or there's an increased incidence of metabolic syndrome, which results in cardiovascular risk. And both these factors put together increase the ovarian follicles, result in anovulation with increased estrogens, and therefore you have menstrual disturbances and subfertility. And all these together can result in psychological issues wherein they are basically due to body image. They have low self-esteem, and there's always an increased incidence of depression and anxiety. We know that about 30% of all infertility patients have anovulation, and out of these, almost 85 to 90% have PCOS. And if you look at the total incidence, it's anywhere between 21 to 59% in the reproductive age group which have PCOS, and the incidence is much higher in South Asian populations, which is about 50% as compared to 20 to 25% in the Western population. And about 30 to 50% have clinical or biochemical signs of anovulation and androgen excess. But when a patient comes to us, we are so much lost, confused. We are so unsure what to do for the patient. We are unclear whether we have really diagnosed the patient correctly or not. And basically, we are also perplexed as to what needs to be done. Because there are several features of PCOS which have similar findings as the other abnormalities what we are going to discuss today. So we know that they are associated with oligomenorrhea and amenorrhea, infertility, first trimester miscarriage, obesity, hirsutism, and acne are main features, as all of you all know. And they also have acanthosis nigricans due to insulin resistance, and also they have male pattern of alopecia. We know that there are several criteria for diagnosis, but what we follow is the Rotterdam criteria, wherein we say that two of these three manifestations have to be there. One is irregular or absent ovulation or hypoandrogenemia, which could be either clinical or biochemical, and polycystic ovarian morphology and ultrasound. But you can see that none of these criteria address the insulin resistance and the metabolic manifestations, which are the main features of polycystic ovaries. And it's also important to exclude other etiologies of androgen excess and menstrual irregularities. And we know that the other etiologies of androgen excess include congenital adrenal hyperplasia, Cushing's syndrome, androgen-producing tumors, either ovarian or adrenal, exogenous sex steroid intake, obesity, and several insulin-resistant states. And there are other causes of menstrual irregularity, which include premature ovarian insufficiency or premature menopause. We could have hypothalamic or pituitary problems, wherein you have a hypo condition, or there are other conditions like being underweight, overweight, chronic illnesses, and uterine abnormalities, which can result in menstrual irregularities. So today, our agenda is that we would have two sessions. The first one will basically discuss on the endocrinological problems as a differential diagnosis, which includes hypothyroidism, hyperprolactinemia, and adrenal disorders, which would then we would have the second session, which would discuss on ovarian tumors, premature ovarian failure, and uterine abnormalities. So the first lecture today is by me, and I'll share my slides. So today I'm going to speak on hypothyroidism as a differential diagnosis of PCOS. And we know that thyroid dysfunction affects many organs, including the male and the female gonad. It interferes with human reproductive physiology. It reduces the likelihood of pregnancy and also adversely affects the pregnancy outcome. We know that the TSH regulates the thyroid hormone production and secretion, and this in turn is regulated, its secretion is regulated by the negative feedback action of the T3 and T4. The thyroid disorders and PCOS are the two most common endocrine disorders in general population, and although the etiopathogenesis of hypothyroidism and PCOS is completely different, these two entities have many features which are in common. We could have two types of situations. One, wherein you have primary hypothyroidism, which mimics PCOS, whereas the second situation is that there is an increased incidence of thyroid disorders in women who have PCOS. So when you take the first disorder into consideration, that is the primary hypothyroidism mimicking PCOS, we know that with this, there is increase in the thyroid releasing hormone, and this increases the prolactin level, which reduces the frequency of GnRH, increases the FSH relative to LH, and therefore there's follicular cyst formation, and therefore you have an appearance of multiple follicles. It also increases the adrenal DHEA, resulting in follicular maturation arrest. We also have increased TSH, and this could result in a spillover effect on the FSH receptors, and it can also result in increased collagen deposit in the ovary, which mimics increased stroma, which is seen with polycystic ovaries. The severity of abnormal ovarian morphology and increased ovarian volume also depends upon the duration and the severity of underlying primary hypothyroidism. Insulin resistance, hyperglycemia, weight gain, metabolic syndrome are features of PCOS, and a similar picture is seen in hypothyroidism due to the associated hyperglycemia, decrease in the sex hormone binding globulin, as well as dyslipidemia, and therefore it also has the features which are seen in PCOS. So if you look at the endocrine features in patients with primary overt hypothyroidism, there are changes seen in the sex hormone binding globulin and estrogen. There is a decrease in plasma binding activity of SHBG, which results in increased plasma concentrations of total and free estradiol. There's reduced rate of metabolic clearance of estrone, and there's also increase in the excretion of 2-oxygenated estrogen. There is changes seen also in the androgen levels with decreased rates of metabolic clearance of androstenedione. The plasma binding activity of SHBG decreases, which results in increased plasma concentrations of total as well as free testosterone. There's also increase in the peripheral aromatization of estrogens to testosterone, and there's decrease in the 5-alpha-beta ratio of androgen metabolites. Changes are also seen in the LH and prolactin level, wherein there's blunted or delayed LH response to GnRH, and increase in the prolactin concentrations may be due to hypothalamic thyroid releasing hormone, increasing both TSH as well as prolactin secretion. And this decrease in the deiodinase 2 activity in the pituitary results in T3 deficiency with increased TSH. But there's a resultant increase in the adipose tissue with the increase in pro-inflammatory markers, which results in insulin resistance. And this in turn will decrease the deiodinase 2 activity in the pituitary. And thus, there is a vicious cycle which is seen in patients with hypothyroidism. The PCOS and PCOS-like subclinical hypothyroidism patients were endocrinologically similar, with the exception that in a PCOS, there is higher C-peptide levels, whereas in patients who have subclinical hypothyroidism, there's a low level of free thyroxine. Usually, these patients present with cold intolerance, dry skin, increased fatigue, as well as goiter. And the clinical features of subclinical hypothyroidism mimicking PCOS are that 14% of the subclinical hypothyroidism patients may present with dyslipidemia, dysglycemia, insulin resistance, ovulatory dysfunction, infertility, obesity, and abnormal menstrual cycle, which mimics PCOS, and high levels of total and free testosterone, LH, prolactin, fasting and postprandial insulin, increased levels of hemoglobin A1C, HOMA-IR, serum lipoprotein, triglycerides, total cholesterol, unfavorable low-density lipoproteins and high-density density lipoproteins, and low levels of SHBG are independent risk factors for the metabolic syndrome and or myocardial infarction in patients who have subclinical hypothyroidism. After treatment for thyroid disorders, there's usually normalization of the ovarian volume in all patients with or without polycystic appearing ovaries. We also know that the second condition which I described to you, that there is an increased incidence of thyroid disorders in women who have PCOS. And basically, it has been seen that the coexistence of hypothyroidism and PCOS has been related to the complex pathophysiological changes caused by obesity and insulin resistance, which is observed in women with PCOS. There is associated pro-inflammatory condition and insulin resistance that leads to decrease in the deiodinase 2 activity with the relative low T3 and higher TSH levels. In the presence of obesity, there's increased leptin levels, which stimulate hypothalamus, causing increased TRH secretion. There's also increased incidence of autoimmune thyroiditis attributed to high estrogen and low progesterone levels, which are present in PCOS. It has also been seen that there is increased estrogen that leads to increased gamma interferon expression and the Th1 cells, and increased expression of the interleukin 6, which is a potent mediator of autoimmunity in T cells. It has been seen that the inflammatory mediators, as described here, induce expression of many functional Fas molecules in the thyroid follicles, which is followed by thyroid destruction via apoptosis, either by the thyroid cell Fas ligand or by the Fas Th1 cells and the T cell proliferation. So pathophysiological pathways connecting these two disorders has not been clearly delineated as of now, but the most obvious connection perhaps is the increased BMI and insulin resistance, which is basically common in both conditions, because we know that increase in BMI is an integral part of PCOS and is seen in about 54 to 68% of the patients, and TSH is higher in women who have a high BMI. So there was a paper which was published in 2019, which looked at the high TSH levels in association with hypoandrogenism in euthyroid polycystic ovary PCOS patients. And this was independent of the age, BMI, and thyroid autoimmunity. So here you clearly see that in those patients who had a high TSH, they had a more hypoandrogenic phenotype, which was significant, which was statistically significant. They also had increased levels of free androgen index, as well as there were decreased levels of SHBG. Whereas if you look at those who had autoimmunity, those who had increase in the free testosterone levels, as well as DHES levels, were also significantly higher, but did not reach that much, that high statistical significance as compared to hypoandrogenemia, free androgen index, and SHBG levels. There was another article which was published in 2016, which looked at subclinical hypothyroidism in PCOS and its impact on presentation, insulin resistance, and cardiovascular risk. So you can clearly see that when PCOS women were compared with the controls, the TSH and anti-TPO antibodies were significantly higher in PCOS as compared to controls. Whereas if you look at the other metabolic abnormalities like hypertension, also as well as increase in the HOMA-IR, cholesterol, as well as triglycerides, HDL and LDL, which was again significantly abnormal in PCOS as compared to controls. And if you look at the hirsutism, which was again significantly higher in women with PCOS compared to controls, the LH levels were higher, whereas the FSH levels, there was no difference which was seen. And if you look at the LH-FSH ratio, it was significantly higher in women with PCOS. Then there was another paper again in the International Journal in 2000 of Obstetrics and Gynecology in 2016, which looked at the hypothyroidism in patients with PCOS, where they did a comparative study of clinical characteristics, metabolic and hormonal parameters in euthyroid and hypothyroid women who had PCOS. And what they concluded was that the presence of hypothyroidism significantly increased the severity of insulin resistance, obesity in PCOS. There was no statistical difference in the LH and FSH levels, the LH-FSH ratio, prolactin, and testosterone levels. The serum DHEA levels were significantly less in the hypothyroid PCOS group, and the concurrent occurrence of both these disorders could also possibly affect other features of PCOS like alopecia and infertility. The other conclusions from the study were that the PCOS is associated with higher incidence of thyroid disorders compared to normal population, especially there is presence of subclinical hypothyroidism and autoimmune thyroid disorders. The cardiovascular risk factors, namely hypertension, dyslipidemia, and insulin resistance, are significantly higher in women with PCOS compared to normal control subjects. And these risk factors, barring hypertension, were further found to be significantly higher in PCOS with subclinical hypothyroidism compared with euthyroid PCOS. The subclinical hypothyroidism status of PCOS does not cause significant changes in other biochemical parameters, with notable exception of the lipid profile. Then in short, I would just like to discuss on PCOS and autoimmune thyroid disorders. And we know that there is an association of PCOS and autoimmune thyroid disease, and this is increasingly being recognized because of its bidirectional relationship. Both share certain common characteristics, risk factors, and pathophysiological abnormalities like polycystic ovarian morphology, adiposity, increased insulin resistance, and high leptin levels, as well as deranged autoimmunity. Though the etiopathogenic genetic factors that operate to create these dysfunctions are dissimilar, they play a very complex role in connecting these two disorders. The complex pathway linking adiposity with in the raised thyroid TSH as well as autoimmunity is basically via the leptin pathway, because in hypothyroidism, there's increase in the TRH secretion from the hypothalamus, which results in increased TSH with increase in adiposity. This in turn increases the leptin. This increased leptin levels in turn again increase the TRH secretion from the hypothalamus, but also result in upregulation of the effector T cells and downregulation of the regulatory T cells, which results in autoimmunity, and thus there's increased incidence of autoimmune thyroid disorders. If you look at the incidence, it's about 27% as compared to 8%, and maybe as a result of hypoestrogenism, proliferative action of estrogen receptors.
Mummy, screen is not visible. Screen is not visible. Your slides are not visible.
No, it is perfectly visible. Madhuri, it is visible. Who said that? Because your slides are visible. Yeah, please go ahead. There must be network problem at that person's end. Yeah.
There's also a proliferative act, and it may be related to a proliferative action of estrogen receptors on beta lymphocytes and the presence of estrogen receptors on the T cells as well as macrophages, and thus patients have higher thyroid antibody levels, and it is also seen that they have a larger thyroid volume, and this is more so in patients who are hypoestrogenic in nature. But it's a great dilemma whether the autoimmune thyroiditis predisposes the subjects to develop characteristics suggestive of PCOS, or whether PCOS is a forerunner of autoimmune thyroiditis still remains a speculation. So my take-home messages from this talk is that the primary hypothyroidism patients share many signs and symptoms with PCOS, such as menstrual disorders, infertility, hyperandrogenism, insulin resistance, and weight gain. The anthropometrical parameters and ovarian morphology were similar in PCOS and subclinical hypothyroidism patients. TSH correlated with the total cholesterol, insulin, and prolactin levels. The only difference was the presence of C peptide, which was higher in the woman with PCOS. The prevalence of subclinical hypothyroidism and thyroid autoimmunity is increased in women with PCOS. High TSH levels in the presence of normal thyroxine concentration should be an exclusion criteria for precise diagnosis of PCOS, and studies designed to treat PCOS with subclinical hypothyroidism with thyroxine before excluding them from true PCOS groups are still necessary. And according to the current recommendations, definitive PCOS diagnosis should be made after exclusion of thyroid dysfunction. So I'd just like to present two cases before I end, which will give us an idea that why hypothyroidism should be excluded in women with PCOS. So this was a 29-year-old patient who was married for 4 years, who presented to us with subfertility for 2 years. She had irregular cycles. She also had history of drug-induced pancreatitis after taking clomiphene citrate. Family history was important because both the parents had diabetes and her sisters had hypothyroidism, and she had failed ovulation with oral ovulations, and 1 cycle of gonadotropins was tried. When we saw her, her BMI was high. It was 26.8. She did have mild hirsutism, and we can see that her antral follicular count was 32 in the right ovary and 37 in the left ovary, with increase in the stroma. And if you look at the hormonal parameters, LH was high, which is again characteristic of PCOS. The androstenedione levels were high, and AMH was 8.4. So probably this was a case of PCOS. And we can see her TSH levels were as high as 22, and her thyroid antibodies were also significantly higher. So what we did is we advised her lifestyle modification, and we reviewed her with the endocrinologist for hypothyroidism, and she was started on 150 micrograms, and fertility treatment was started only once the TSH came back to normal after 3 months, wherein it was 3.4, the free T4 was 0.96, and the thyroid antibody, though it had not become negative, but it had definitely reduced. So we gave her initially letrozole because now her thyroid was normalized, but we saw that there was no ovulation. And then we started her in the next cycle with the recombinant FSH in the dose of 37.5. And as the levels were, E2 levels were very low, what we did is we increased the dose to 50 IU, and further we had to increase the dose. We had 3 dominant follicles, and ovulation happened on day 29, and we did an IUI, and there was no pregnancy. In the next cycle, we started her with 75 because this was the threshold dose. So this is very important that the first gonadotropin cycle will give us the threshold dose. And therefore, here we started with 75. We had a single follicle on day 20, and then again, there was no pregnancy. So in the next cycle, what we did is we said that we should go for IVF, and we started with a very low dose, and then we increased the dose to 150. And on day 18, she had 7 follicles, 13 to 14 millimeters. She was basically for IUI. So we counseled her for IVF, and we started antagonist, and we gave REC HCG when there were 8 follicles, 17 to 18 millimeters. The E2 was 20-25. The oocyte retrieval was done. We had 7 oocytes, 5 fertilized, 2 blastocysts transferred on day 5. And she had a pregnancy confirmed by rising beta HCG as well as there was a gestational sac, and she's had a live birth rate. So once a viable pregnancy was confirmed, her TSH was remeasured and it had increased to 10. We know that pregnancy increases the TSH, and therefore the thyroxine was again increased to 175 on Monday to Friday and 150 on Saturday and Sunday. After 4 weeks, her TSH was 0.37. So the same dose was maintained. Glucose tolerance test was done at 10 weeks, which was normal. And at 11 weeks, she developed hepatitis, and all infections were ruled out. The gastroenterologist diagnosed it to be drug-induced due to progesterone, which was stopped, and her LFT returned to normal after 3 weeks. TSH was regularly monitored every 6 weeks, and then she had a normal delivery. On the other hand, this is another patient wherein she was 20 years unmarried. She had irregular cycles. She was diagnosed as PCOS outside. She came to us, we did a transabdominal scan, and the volume of the ovaries was less. It was 9 and 8. And we know that in an adolescent, basically, it is important to have an ovary which is more than 10. But she had an antral follicular count of 18 in the right and 16. And if you look at her hormonal parameters, they were all normal, though the TSH was high and the antithyroid antibodies were negative. But her free T4 was also low. So we started her on 500 milligrams of thyroxine, and we repeated after 3 months. And you can see that her free T4 increased as well as her TSH was also normal. The menstrual cycles became regular after 5 months and are regular even after 1 year. She's on regular follow-up for a thyroid profile, and a polycystic appearance of the ovary also has reduced on a transabdominal scan. So these were 2 examples wherein PCOS can result in thyroid abnormalities. And the second case was, it was hypothyroidism, which has resulted in a PCOS-like picture. And therefore, it's important that we have to exclude hypothyroidism in any patient who comes to us. And I thank you all for a patient hearing. So now we have our second lecture today is on by Dr. Pratap Kumar, who will talk to us on hyperprolactinemia as a differential diagnosis of PCOS. He is the head of the Department of Reproductive Medicine and Surgery at the Kasturba Medical College and Manipal Academy of Higher Education at Manipal, Karnataka. He has been the Vice President of FOGSI. He is the examiner for the National Board and for various, for undergraduates and postgraduates in several universities. He was president of the KASOGA and member of the Task Forces of Human Development and Disease. He has several awards and publications to his credit, and he's a teacher par excellence. Over to you, Dr. Pratap Kumar.
Yeah, thank you very much. Let me share the slides, and you're able to see my slide?
Yeah.
Thank you very much, ICOG Chairperson, Dr. Lakshmi Shrikande, Dr. Madhuri Patil, and all the office members of this society, as well as FOGSI. As a differential diagnosis, hyperprolactinemia is one of the problems to be evaluated, because some of these polycystic ovarian patients do come with galacturia or hyperprolactinemia. But let us see the other way around as well. Now, when we know that prolactin is a stress hormone, and it can be induced with any kind of stress in the body other than actual organic problem, the sleep-related circadian rhythm. So I would start off by saying that even if you want to really estimate prolactin, it should be done in the morning and fasting mid-morning at 8 to 9. Circadian rhythm, where the prolactin can be produced in the early morning of the day. Now, there are different kinds of molecules. There's something called small prolactin, big prolactin, and big prolactin. But
Pratap, please unmute yourself. Dr. Pratap.
Okay, I think they muted me.
Yeah.
Okay, see, the small molecules are the one which we actually estimate in the prolactin level. The big and the big ones are there in the body, but I always wondered why it is there. We are not able to estimate that. And I don't think there's any physiological function at the moment understood by that. So let's concentrate only on the small prolactin, molecular weight of 22,000. Now what happens is, I'm sorry, this is not moving. Oh, my slide is not moving next. Yeah, the prevalence is 0.4 to 5%. All these women have amenorrhea around 9%. They have galacturia about 25%, and amenorrhea and galacturia about 70%. And men who also can have impotence, prolactin has to be done. But today the topic is not on the men, but it's only on the PCO and the differential diagnosis. Now, how does this really produce a problem? The dopamine has the dominant influence of prolactin secretion. The secretion of prolactin is under tonic inhibitory control by these kind of agonists. That is why when we give any medicine, they call it dopamine agonist. The dopamine will basically have a control over prolactin secretion. And if you find the prolactin goes up, there can be a problem with galacturia as well as the other coexisting problems. So we know that the secretion of prolactin under tonic inhibitory control of dopamine. That means if you give dopamine agonists like bromocriptine and cabergoline, it helps in the control of dopamine very well, and they go down, the prolactin levels go down. So when you look at the hyperprolactinemia, it increases in circulating prolactin levels, usually producing reproductive problems in both sexes, especially with anovulation and in women. Defines prolactinemia, WHO said above 25. So it shall be done fasting, and around 1/4 of women have also amenorrhea and oligomenorrhea, and 30% will have galacturia and infertility. 75% with both amenorrhea and galacturia. And look at these varied pictures we find in clinical practice. We find that the hyperprolactinemia mechanisms on reproduction basically is number one connected to GnRH secretion. It interferes with gonadotropin action in the ovary, interferes with estrogen positive feedback, inhibition of FSH directed ovarian aromatase, inhibition of progesterone synthesis, impaired follicular development, and finally, inhibition of 5-alpha reductase enzyme in men. Today, we're not going to talk about that. However, I would like to emphasize on this particular slide by saying this particular problem of hyperprolactinemia also definitely has a reproductive dysfunction and, of course, a problem further. So when somebody has galacturia, we very well know about it. But when somebody has oligoovulation, luteal phase defect, anovulation, we miss on this estimation of prolactin. So definitely a woman with irregular menstrual cycles and of course galacturia, there's no doubt about estimation, because just by looking at the irregular menstruation, somebody should not be diagnosing PCOS. PCOS is another alternative diagnosis. However, if you find hyperprolactinemia along with irregular cycles, that probably causes galacturia, prolactin itself. So that is why we always find, of course, the men have all other problems. So when you look at this, simple pain, nipple stimulation, of course, pregnancy, even an examination of the woman, and if she doesn't sleep well, and of course, exercise also can increase this like a stress. But somebody may be having some other kind of drugs for some other reason. They also can be having hyperprolactinemia, and all these are connected to different problems as such. And the drugs causing functional hyperprolactinemia can be antipsychotic, antidepressants, antihypertensives, antiemetics, opiates, and others. That is why instead of wrongly diagnosing as PCOS forever, as Dr. Madhuri Patel said, this session is basically to exclude the other problems. I would like to emphasize of hyperprolactinemia, which may come with irregular cycle and wrongly diagnosed as PCOS. The history taking is absolutely important. And of course, medication as to what are they. We usually don't get this history because antipsychotic depressants, they never come and tell us. They go to somebody else and they hide their prescription in their bag. So we know that if on talking to them pretty well, they would probably come out with these kind of story. Of course, the gross ones are the pituitary tumors, lactotrope hyperplasia, empty cellular syndrome, and so many things. However, 80% of all these adenomas secrete prolactin. Most common pituitary prolactinoma is microadenoma, when less than 1 centimeter, and macroadenoma is larger. I'm not going to talk about it. When we talk about craniopharyngioma, it seems to be the hypothalamic cause, and is also called as rat case pouch tumor. Grossly, they can be cystic, solid, and mixed, and calcification is usually visible on X-ray examination. However, we are not talking about that today because we have experts of neurologists who do MRI and also diagnose the same. There's something called as empty cellular syndrome, an intracellular extension of the subarachnoid space resulting in compression of the pituitary gland and enlarged cellular tashika that may be associated with galacturia and hyperprolactinemia. These are not diagnosed by us gynecologists or fertility experts. We have to refer them. If you find the prolactin is not coming down and if you have evaluated well before, I think these pituitary neurological diagnoses can be done with a neurologist. Now, when you look at the hypothyroidism, as mentioned by Madhuri just now, around 3 to 5% of hyperprolactinemia have hypothyroidism. It's also associated. Hence, TSH should be measured in all individuals with hyperprolactinemia as well as PCOS. So when you look at the size, less than 1 centimeter means it's usually 200 and below. 1 to 2 centimeters, 200 to 1000 nanogram, and greater than 2 centimeters will be above 1000, much higher. Above 200 nanogram, I think indicates a presence of adenoma. And if MRI can be asked, I think safer side to be 100 nanogram. MRI is done to rule out prolactin producing tumor. MRI can detect adenomas, a very small one, 3 to 5 millimeters. The rough value is varying in different pictures, different textbooks. But I think I for one would think 100 nanogram is a nice number to remember, and MRI can be asked for. But definitely do not miss peripheral field vision, because supposing she conceives, there is no point in doing prolactin level. Prolactin goes up in pregnancy anyway. In pregnancy, the tumor can grow. Hence, in these patients, peripheral field vision is done once in 3 months in pregnancy to be sure that she has no problems of the eye. But at the moment before pregnancy, we know peripheral field vision will tell us the idea about where the problem is. Now, there's something called hook effect. Sometimes a grossly elevated prolactin level simultaneously saturates both the capture and the detection antibodies, preventing immunoassay sandwich formation and quantitative detection of prolactin. What does it mean? Sometimes a very large tumor can be missed by just by prolactin level. It may look normal. So to distinguish the large prolactinoma from non-functioning, the laboratory would do 1 in 1000 dilution and recheck prolactin. So when you suspect through the MRI something is wrong and you find prolactin is normal, and that's called as hook effect, this has to be basically discussed with the biochemist and once again do the dilution and get the right kind of a value. However, it's easy to understand there are 4 main causes of hyperprolactinemia. Pregnancy we're not talking about today. Drug abuse or not abuse, drug use itself is a cause. Hence, history taking is very, very important. Rule out thyroid problems and of course pituitary problem as well. Suppress prolactin secretion, reduce the size of prolactinoma, and prevent progression and recurrence are the main 3 goals in medical management. When you give dopamine agonist, that's what I said, you give dopamine agonist, this enhances the dopamine action. They're the preferred treatment, and it lowers the serum prolactin level, eliminates galacturia, restores gonadal function, and decreases tumor size. Bromocriptine seems to be the commonest one, easily available, as well as the other one, cabergoline. But there's an age-old treatment of bromocriptine, but they all have side effects: nausea, vomiting, dizziness due to postural hypertension, headache, nasal stuffiness, drowsiness, fatigue, abdominal pain, and leg cramp. So you can imagine how horrible this woman would be feeling with bromocriptine. Hence, it's always given in a small dose. I normally start with a dose with the food at night time, and maybe mild, most are mild, occur early in the course of treatment and are transient. I'm talking about the symptoms. I increase gradually every 2 weeks. I start with this 1.25 milligram, once a day, then twice a day, then 3 times a day. And every 2 weeks, I would call up for the prolactin level and also look at the endometrium, because endometrium will start growing. When the prolactin goes down, estrogen will go up. So you'll realize every 2 weeks, I would like to see the endometrium. This is another thought of mine. No book tells clearly about it. But I've had good pregnancy rates with this kind of a management. I would have to try to repeat now. You start with 1.25 milligram once a day, make it twice a day, make it thrice a day, but you can do 2.5 twice a day, depending on the response of prolactin reduction. I would add on endometrial evaluation, because as the estrogen goes up, you'll find triple line endometrium, and thereby you know she's going to ovulate. So sometimes, though there's no point in calling after 3 months and 6 months. Every 2 weeks for fertility reasons, you have to call her. Another very strong one is cabergoline. Is an ergoline derivative with a high affinity and selectivity for D2 receptors. Unlike bromocriptine, cabergoline has a low affinity for D1 receptors. half-life of approximately 65 hours, allowing once or twice weekly. So this seems to be interesting, just twice a week or ideally twice a week, because, but one thing is you should define the days of which they have to take, and they keep forgetting it. But over the years, I've realized this cabergoline is quite strong and the bromocriptine is not so strong. So, but the effect is quite good when you wait. Both of them are very effective. So you can choose. However, though cabergoline is more effective than bromocriptine and of course tolerated, it's a little more expensive and we can give it twice a week. Discontinue cabergoline 1 month before conception is attempted. However, if she misses the period, you stop everything. So finally, we know the difference between cabergoline and bromocriptine. They're basically the bromocriptine, the receptor target sites are D1 and D2. Cabergoline is high affinity for D2 receptors. Duration of action is 8 to 12 hours. Cabergoline takes a longer time. Half-life is 3 hours. Another one is 65 hours. And available dose, as I mentioned, I've told you about that. It is either 1.25 or 2.5. And of course, you can get 5 or 10 as well. But the cabergoline is 0.5 milligram up to 1 milligram you can give. And you'll find that the advantages are long history of use does not appear to be teratogenic and inexpensive. Though cabergoline is effective, it's expensive, but of course you can try that. Not really so expensive when you compare to the other gonadotrophins, what we use in clinical practice. Disadvantage of bromocriptine is the tolerance is not too good, and they do not take it every day as we have mentioned. And the disadvantage of cabergoline is not very much of a problem. The common side effects are, which I mentioned about bromocriptine, and cabergoline is pretty less. So the options are for resistant cases. Supposing you've done all this and you don't find the response, then you switch out to another alternative treatment. Raise the dose of the dopamine agonist beyond conventional doses if the patient continues to respond and tolerate. And the last resort is, of course, surgical resection, which is not done commonly. Radiotherapy is not done commonly. Experimental treatment with other drugs is not very much discussed. Surgery is only for patient drug tolerance and resistant cases to medical therapy or persistent visual field defects in spite of medical treatment. And of course, transcranial surgery is the accepted one if there is a problem. Radiotherapy is called stereotactic radiosurgery, has become more popular because MRI allows more accurate resolution. And this can be considered in patients with macroadenomas who are resistant to or intolerant to medical therapy, and when we fail the other kind of modalities. So this is the last part of my story of the presentation. I just want to emphasize that just add on to your clinical value of endometrial proliferation. When you find a nice triple line endometrium like this, we know the estrogen is good, prolactin is going down, and you start inducing ovulation when sometimes they ovulate on their own. However, polycystic ovary syndrome, along with prolactin, when you bring it down, you may have to add on induction of ovulation with letrozole for these kind of things. But today's discussion is other than polycystic ovaries, what are we going to do? So prolactin is basically assessed in these kind of anovulatory women. Mid-morning fasting, how long should the patient be followed up after withdrawal? The withdrawal has very different studies. Generally, patients have been observed for 1 to 5 years after cessation of treatment. Most patients relapse within first year, during which the patient should be subjected to a stricter monitoring of prolactin levels or very frequently. And of course, pregnancy concerns are the growth of the tumor because of high levels of estrogen leading to visual disturbances. And of course, we do not give dopamine agonists in pregnancy because of embryogenic problems. And to conclude my presentation, I will repeat, hypoprolactinemia is suspected when amenorrhea and galactorrhea is present, and do not brand everybody as PCOS, as Madhuri Patil has emphasized at the beginning. Rule out hypothyroidism, and she brilliantly said how hypothyroidism can cause a kind of a PCO kind of a picture and also causes galactorrhea. Prolactin greater than 100 nanogram, MRI is indicated, and we have only 2 choices in the medical management, bromocriptine or cabergoline with the choice of treatment. Thank you very much for invitation and for requesting me to do the presentation.
Madhuri, unmute.
Thank you very much for that excellent talk, Dr. Pratap Kumar. And now we'll have the Q&A after the third talk. And so I would request all the participants to put in your queries in the chat box or the Q&A section, and we would have them. And then we now have Dr. Shervil Gadve, who is going to speak to us on adrenal disorders. He's an endocrinologist and he's Director-in-Chief for Endocrinologists at the Excel Endocrine Center in Kolhapur. He's a teaching faculty of Public Health Foundation of India for training of physicians in diabetes, thyroid disorders, lipid disorders, and gestational diabetes. He is also a principal investigator in multiple global phase 3 and 4 clinical trials, and his area of research include GDM, type 2 diabetes, obesity, and diabetes technology, and is member of the American Association, ESI, PCO Society, Growth Hormone Research Society, and several other societies. And I request him to start his presentation. Over to you, Dr. Shah.
Is my screen visible?
Yeah, you need to just put it on slideshow.
Yeah. Able to see the first slide? Yeah.
Yes, we can.
Yeah. Thank you, Chairperson, for that kind introduction. Good evening, everyone. It's a pleasure to be here discussing this very important topic. So my topic is, I'll be discussing on adrenal disorders, that is congenital adrenal hyperplasia and adrenal tumors. So we know that the differential diagnosis of PCOS encompasses many different differential diagnoses. So be it the thyroid disorders, which has already been discussed, then comes the differential diagnosis of hyperprolactinemia, primary ovarian failure. We have the pituitary causes, the Cushing disease, acromegaly, the non-classic CH and adrenal. We have the androgen secreting tumors from the adrenals. So that is one differential diagnosis. And then comes the differential diagnosis of idiopathic hirsutism, obesity, insulin resistance, pregnancy, and so on. So the purpose of this talk is focusing on non-classic CH and androgen secreting tumors from the adrenals. Now, what is this adrenal gland? Now, if we have to consider all the endocrine glands, be it the pituitary, the thyroid, the adrenals, and the ovary, and let's say we are in a very terrible situation and we are left on an island and we are given an option of sacrificing one of our glands. Now, if we choose to sacrifice our adrenal glands, we will not be able to survive on an island for more than 1 hour. That is how critical the adrenal gland is for survival. Now, let's say somebody is not having their thyroid hormones in place. The person can pull on for some time. Same is the case with other hormones. But the adrenal hormones are the most crucial hormones, I would say. And if somebody has complete adrenal insufficiency, that requires immediate supplementation. So that is how important are these suprarenal glands, the adrenal glands. Now, when we consider congenital adrenal hyperplasia, what are we talking about? So this slide here shows the different steps of the adrenal steroidogenesis pathway. And just to make it more pictorial, I have color-coded the different hormones here. And if you look at the concentration of the hormones that we measure, in fact, glucocorticoids happen to be the most enormous hormone produced by the adrenal gland, followed in frequency by other hormones. And when we are talking of CAH, that is congenital adrenal hyperplasia, we know that we measure 17-hydroxyprogesterone and other hormones to make a diagnosis. This is a complex slide. It involves multiple differential diagnoses. The enzymatic block can be at various places. And what is more common is what we see is CH. Now, just to make it more simpler, this is the block that we are talking about. The P45021A2. And when there is a genetic cause of a block of this hormone, the hormones upstream of this pathway are regulated, and the hormones downstream obviously get downregulated. Now, what are the hormones upstream of this pathway? As is obvious here, we see 17-hydroxyprogesterone, which we commonly measure to diagnose congenital adrenal hyperplasia. We also realize that these patients have high levels of progesterone, as this also happens to be upstream of this steroidogenesis pathway. Now, this is a very complex pathway, and because of the block here, the upstream components of this steroidogenesis pathway get upregulated. And you can see all this translates into androgen excess, variable glucocorticoid, and mineralocorticoid deficiency. So we see a spectrum of manifestation of congenital adrenal hyperplasia. Somebody having the severe phenotype will present as early as in infancy with salt wasting CAH, which is an emergency. The child has to be diagnosed in infancy and treatment has to be continued for the rest of the life. On the other hand, we have adult onset 21-hydroxylase deficiency, which is a very subtle phenotype. Many a times it is undiagnosed, and we may have to do specific tests to diagnose. Many a times this diagnosis is considered as a differential diagnosis of PCOS. Also, in the workup of cases of infertility, we need to keep this steroidogenesis pathway in our mind to have an appropriate diagnosis. Now, what is this CYP21A2 mutation? So here we see the genotype-phenotype correlation. What I just alluded to, deletion, X3 deletion, X6 clusters, the R356W, all these mutations form the classical salt wasting CH, where the enzymatic activity is practically 0%. On the other hand, the other extreme is the non-classic CH. Typically, the genetic defect is the V21L of the CYP21A2. So here you see there is some enzymatic activity remaining. That is almost 20% of the enzymatic activity. So these individuals present in adulthood. And one of the differential diagnoses for PCOS. And there is an entire spectrum. You may have the simple virilizing forms of CAH, where the enzymatic activity is much less than the non-classic. So again, the mutations here are different. This is an entire spectrum. Manifestations can be ranging from childhood to adulthood, depending on what is the genetic defect. Now, let's focus on 17-hydroxyprogesterone levels in PCOS. Now, this slide here shows the 17-hydroxyprogesterone normogram for diagnosis of 21-hydroxylase deficiency, which is the stimulated value. The gold standard happens to be the stimulated value. So you give cosyntropin, you stimulate with cosyntropin and measure 17-hydroxyprogesterone at 1 hour. So if you look at this distribution of the different levels of 17-OHP, this here is the classical CAH, where the levels of stimulated 17-OHP are very high. They can be as high as 1 lakh nanogram per DL. On the other extreme, these are the unaffected individuals, so normal individuals. If you do this test in normal individuals, the 17-OHP levels are very low as below 100 nanogram per deciliter. Now, in between these two extremes, on the one hand, you have non-classic CH. Here, typically, the values of the stimulated 17-OHP range somewhere around 10,000 nanogram per deciliter. And then again, you have the CYP21 heterozygotes, who again overlap their values between the normal and the non-classic CH. And interesting thing is, if you do this test in all patients of PCOS, you again see here some overlap between the normal and the levels seen in non-classic CH. So this slide here shows the distribution of 17-OHP across these various phenotypes. The Endocrine Society guidelines they strongly recommend diagnosis of non-classic CAH in adult women with basal 17 OHP value greater than 200 nanogram per deciliter and then confirmed with an ECTH stimulation test. Now, let's say tomorrow we see a patient with PCOS. We are suspecting whether it is non-classic CAH. We should do a basal 17 OHP level. For initial screening, morning serum sample for 17 OHP concentration should be obtained during the follicular phase of the menstrual cycle, if the woman is cycling regularly. For women with amenorrhea or infrequent menses, the sample can be drawn on a random day. That is the basal level. Now, let's say your basal level of your patient's sample is more than 200 nanogram per deciliter. Then you go ahead and do a synactin stimulation test. Now, synactin is not available in India, but what is now available is known as Sintropac. So we have an injectable readily available by the name of Sintropac that is equivalent of synactin. So we give that in the dose of 250 micrograms CTH. And we do this test, the stimulated test. The response of CTH is exaggerated, non-classic CH, because we saw the enzymatic block. So if you stimulate these precursors, there will be a surge in 17 OHP level. The value will go above 1500 nanogram per deciliter. This confirms the diagnosis of non-classic congenital adrenal hyperplasia. So that means you are not just dealing with the garden variety PCOS, you are actually having a case sitting in front of you of non-classic CH. Now, we know in medicine, everything is not always black and white. There are always overlaps. Now, if you have an overlap of the value, what are you supposed to do? Now, you see, if the stimulated value at 60 minutes in affected patients ranges from 1000 nanogram per DL to 1500 nanogram per DL, this range is inconclusive. There we need to take help of the genetic test. You can order genotyping of the CYP21A2 gene. That is possible. Now, that is how we diagnose CAH. Be it classic CAH, be it non-classic CAH, we saw the different cutoffs and the basal and the stimulated values. Now, why are we bothered about 21-hydroxylase deficiency? How does it manifest in an adult female? The manifestations in children is altogether a large topic to be discussed. But today we keep our focus on the adult female with 21-hydroxylase deficiency. So what is the pathology? So we see that these women will have high androgens, but it is not just about androgens. It is also about high progesterone. They have high progesterone levels. They have anovulation. And there are other reasons which can lead to infertility, including inadequate introitus, vaginal stenosis, restenosis, and so on. Now, presently, as we know that large number of patients may have undiagnosed non-classic CAH, but we also know that there are large number of patients who are diagnosed cases of classic CAH as children, and they also have transition into adulthood. Now, if we look at this subset of patients and consider what happens to their chances of conceiving. So the fact is that less than 25% attempt conception. If they attempt conception, pregnancy rates achieved can be up to 90%. Salt wasting variety is less likely to attempt conception. We should discuss genotyping the partner as well, because we don't want the baby of this child to have again classic 21-hydroxylase deficiency. So genotyping of partner is also important. In extreme cases, there is role of therapy with unilateral or bilateral adrenalectomy as well, but that is the extreme what we do. Now, how do we treat patients with CAH? So basically, we saw that there is an enzymatic block, and these patients are deficient in glucocorticoids, mineralocorticoids, and that leads to excess of androgens and progesterone. So the treatment is basically physiologic steroid replacement in the form of hydrocortisone, or whenever hydrocortisone is not possible, you can consider prednisolone. These are all the options, the frequency. The most physiologic way of replacing is giving hydrocortisone twice or thrice a day. And then there are these other options. We may also need to give a bedtime dose of prednisolone just to suppress the morning ACTH, which is very common in these patients. Now that was about classic CH, but today we are discussing about non-classic 21-hydroxylase deficiency and the fertility prospects. So in these cases, the fact is that a certain rate is low. That is, many patients are not diagnosed. Less than 15% present for infertility. The remaining may actually conceive spontaneously. 80 to 96% pregnant in 1 year with or without treatment. There is high rate of miscarriage, 6 to 14% with hydrocortisone treatment and 20 to 26% without hydrocortisone treatment. So clearly, if you have diagnosis, you should be treating these patients with hydrocortisone to reduce their rate of miscarriage during pregnancy. Now we know that this defect can also happen in men presenting with infertility. Due to paucity of time, we will not discuss this today. We will restrict the talk to females with CH. And as I already discussed, considering genotyping the partner is important. Stress dosing can be required. Now we know that in children or with cases with classic CH, we always stress upon this important advice to the patient, that is stress dosing. Similarly, we need to keep in mind that adults with CH may also require stress doses of steroids. Now, what about treatment during pregnancy? Now, during pregnancy, women with non-classic CH should preferably be treated with hydrocortisone. Why hydrocortisone? Because pregnancy is accompanied by elevated stress levels and as a preventive measure against the high incidence of miscarriage. Hydrocortisone is favored due to its metabolism by the placental enzyme, that is 11-beta hydroxylase type 2, which prevents glucocorticoid from having any effect on the fetus. So if you have diagnosed non-classic CH and the female conceives, you need to consider all these facts while treating her. Now, that was about non-classic CH, and also we touched upon the classic CH. Now, what about the other disorders from the adrenal gland, which can mimic polycystic ovary syndrome? Now, let's say a female comes to for your advice and is very much hirsute. You see that the patient obviously has clinical hyperandrogenism. So how do we evaluate her? We should do a testosterone level. If the testosterone level is more than 200 nanograms per deciliter, we can do a ACTH test as well. Now, if you do a 17 OHP and if the baseline level is quite high, you consider non-classic adrenal hyperplasia. We already discussed that. If you do a DHEAS level along with testosterone, and if the DHEAS level is more than 600, then you're dealing with a case of adrenal androgen secreting tumor. So how do we suspect an adrenal androgen secreting tumor? It is looking at the testosterone level and looking at DHEAS, which if it is high, that is a adrenal androgen secreting tumor. The DHEAS, this is a typo here. If the DHEAS level is very low, then that is the non-adrenal cause. Now, clinical presentation in individuals with non-classic CH due to 21-hydroxylase deficiency, we can see that the presentation can be either in girls, in women, in boys, or in men. And in girls, the presentation is with hirsutism. In women, the presentation is with hirsutism, menstrual cycle disorders, acne, infertility. They may present with alopecia, acromegaly. All these can be the features. This is a very busy slide. It shows various age groups and what do we do, how do we intervene, ranging from children to adolescents to adult females and so on. I'll skip this slide. Just move on with the differential diagnosis of adrenal causes. Now, we may have an adrenal cause which can mimic PCOS in the form of Cushing syndrome. So you may have a patient with an adrenal mass which is manifesting as Cushing syndrome. There you need to diagnose whether it is actually endogenous Cushing syndrome or exogenous Cushing syndrome. So we know we take help of the different tests involving the hypothalamo-pituitary adrenal axis. We measure the cortisol levels, we measure aldosterone, we measure androgens, we measure ACTH. And we also do dynamic tests. We do an overnight dexamethasone suppression test and different tests. So here I have just put in few clinical cases which pictorially we can make out. So this is exogenous Cushing syndrome. This is endogenous Cushing syndrome. There is a lot of overlap. Endogenous Cushing syndrome, we need to further work and do imaging for the adrenals. On the other hand, exogenous Cushing syndrome can be due to excess exogenous corticosteroids given. They can again mimic as PCOS. So these are different mimics of PCOS. And body habitus helps us in diagnosing Cushing syndrome. So here you see 3 different photographs. Now, on the first and the second photograph, we obviously suspect that there is some pathology. But let's say there is a person like on the third part of this slide who may also have an underlying etiology, but is just not diagnosed because the clinical manifestations may not be obvious. So we need to have a high index of suspicion not to miss out on these cases. Photographs are essential. Now, if you have some girl coming to you as seen here on the right-hand side with PCOS, if you look at the patient's previous photographs, you can make out subtle differences, which can be a pointer towards the possible etiology of Cushing syndrome or an adrenal cause or a pituitary cause. There is another patient of ours who presented with PCOS and subsequently was diagnosed to have Cushing syndrome. She was treated for Cushing syndrome, and that is how she improved. So it is very important that we don't mislabel a patient of adrenal origin presenting with hyperandrogenism as the garden variety PCOS and miss out on the diagnosis. There is another patient who presented with hirsutism. This is an elderly postmenopausal female presenting with hirsutism. She happened to have an adrenal mass. Her DHEAS levels were high. Her testosterone level was also high. That is how we suspected that. And whenever we say adrenal tumors, we are also worried about the more malignant causes of adrenal tumors. That is ACC, adrenal cortical carcinoma. It is a rare malignancy, but it has a very bad prognosis. How common are adrenal masses? Now, this is an estimate from India. So roughly, if you go and look at all incident telomas in a population-based survey, number of patients presenting with adrenal incident telomas can be quite high. Now, what are the different types of adrenal neoplasms? So here you see the first photograph here is of a case of adrenocortical adenoma. They may again present with obesity, Cushingoid features, PCOS-like presentation, facial puffiness, and so on. And you can see it is often curable with surgery, resect the adenoma, and this is before and after. Other differential diagnosis is adrenals are prone to metastatic disease as well. So a patient with known neoplasm may present with an adrenal mass as a metastatic manifestation. And here the prognosis is poor. Pheochromocytoma. So you may have some female presenting with puffiness, hypertension, paroxysms of hypertension, and so on. So this is a diagnosis of adrenal mass in the form of pheochromocytoma. So this requires appropriate treatment. And adrenocortical carcinoma. So this can also mimic as hirsutism, obesity, facial puffiness, and so on. So it is rare. Incidence is 2 to 3 cases per million, but it is often fatal, and early diagnosis and treatment, surgery, and mitotin is what is required. So this is a broad spectrum of adrenal tumors which we should consider whenever we suspect the adrenal tumors as a cause, as a differential diagnosis of PCOS. Now, simple thing to be kept in mind is whenever you are suspecting an adrenal tumor, the simple test what we do is a CT scan. If the unenhanced CT scan shows less than 10 Housefield as the manifestation, which is lipid-rich adrenocortical adenoma, it is usually adenoma and not carcinoma. the specificity and sensitivity is quite good. And if it is more than 10 HU, that is a lipid poor mass, that is a grave prognosis. So that tells you're dealing with adrenocortical carcinoma or pheochromocytoma or metastatic lesion. So that makes the differential diagnosis more worrisome. This is how less than 10 HU looks on CT scan. This is how myelolipoma looks. This is a benign cause and surgical dissection cures it. And this is how something more than 10 HU will look. Sensitivity is 70 to 85. And we need to consider the differential diagnosis that I discussed. So we have looked at the spectrum of CAH ranging from classic CAH to non-classic CAH. We've looked at different adrenal pathologies, which can span from benign adenomas to Cushing syndrome to the adrenocortical carcinoma, which is a very rare differential diagnosis of PCOS. So all this has to be kept in mind, and that completes the discussion about the adrenal causes of differential diagnosis of PCOS. I will stop here and hand over to the chairperson for further discussion. Thank you.
Yeah, thank you very much, Dr. Sherville, for that excellent talk. So here we have seen that both hypothyroidism and adrenal disorders basically mimic PCOS because they have features or they are united basically by the metabolic syndrome. So they have features, all related to the metabolic syndrome, and therefore we have to consider these as differential diagnosis of PCOS. And when we look at hyperprolactinemia, we know that the incidence of hyperprolactinemia is also high in women with PCOS, and it's anywhere ranges between 3 to 67%. And basically it is related to insulin resistance. So if you have a patient who has got hyperprolactinemia and you see that there's no insulin resistance, then probably hyperprolactinemia may be the primary cause. And why do we take into consideration hyperprolactinemia as a differential diagnosis? Basically is because we know that it results in menstrual disturbances, and one of the symptoms of polycystic ovaries is menstrual disturbances. And we also know that it can have effect on the reproductive dysfunction, as very well described by Dr. Pratap Kumar, because it can have effect on the follicular development and also on the secretion of the hormones from the hypothalamus as well as the pituitary. So we'll go to the question answer section now. And so the first question was to me, and that is, what is spillover effect of TSH? So basically the spillover effect of TSH is that TSH has some amount of action like FSH and LH, and that's called as the spillover effect. And it also has an effect on the FSH receptors. And this effect on the FSH receptors can then result in whatever signs and symptoms what you are seeing. The second question was TSH of 0.37 after 4 weeks of correction. Is it too low? Yeah, actually, yes. It must be low, but the patient was taking the thyroid medication in consultation with the endocrinologist. So it is the purview of the endocrinologist whether to decrease or increase the dose or keep the dose same. And I think the dose is maintained same because we know that pregnancy is associated with high TSH levels. And usually all patients who have become normal, having normal TSH levels after treatment, once they become pregnant, especially our infertility patients, we see that their levels again increase, and therefore probably the dose is maintained at that particular level. Then there was a question to Dr. Pratap Kumar is, do hyperprolactinemic patients respond well to oral ovulsions, and how often gonadotropins are required in these patients?
Yeah, we don't start any induction of ovulation until the prolactin becomes normal. Otherwise, it doesn't act well. And so you start with letrozole because it's a quite effective drug. And if it doesn't work well, then you can add gonadotropins. I would probably, the first cycle, I would start with, if the PCO also associated with letrozole is the choice, 2.5 milligram once a day or twice a day, depending on your choice. And then you go on there's no follicular genesis, as Madhuri Patil has beautifully told, how she increases from 37.5 to a little higher than that. I think there are different regimes you can try that.
Yeah. If any more questions? And I think all of us need to keep in mind that adrenal cause is also a very important differential diagnosis, because most of us, we do look at hypothyroidism as well as we look at hyperprolactinemia, because basically they are more related to the obstetrics and gynecological field, and we know that it can affect. But in patients wherein you see the features which are suggestive of adrenal adrenal tumors, it's very, very important that you have to rule out, especially rule out adrenal cause, especially when you see that there are elevated 17-hydroxyprogesterone levels.
There's one question, Madhuri, by Dr. Shubhara, which I've answered on the chat line. Her question is, if it's prolactin more than 170 and absolutely no symptom of headache and visual disturbances, should we do MRI? My answer is yes, because sometimes they don't have headache, but they can have only prolactinemia. So anything above 100, I think better to be careful and do the MRI.
Yeah.
So I would like to make a comment. So if we see any discrepancy in the hormone level and the clinical manifestation, so it can be in the form of prolactin, it can be in the form of TSH. One thing also probably we need to keep in mind that we should ask the patient to discontinue all their multivitamins at least 48 hours before the testing. So one explanation is, if the patient is taking high levels of biotin, so this biotin interferes with the electrochemiluminescence assay, which is used to measure these hormones. So whenever there is clinical discrepancy, we need to take patient's history also and look for this biotin, which is now becoming more common culprit for the mismatch between clinical presentation and the levels. Also, we know that for prolactin, there is this phenomenon of macroprolactin, which has already been discussed. So we need to maybe repeat the sample as in a different way to remove the interference of macroprolactin.
Okay.
So if there are no more questions, probably we'll go to the next session. And actually, this talk was supposed to be taken by Dr. Neena Malhotra, who is a professor at the ART Center, Department of Obstetrics and Gynecology at All India Institute of Medical Sciences. She's undergone her training in ART in UK as well as in US. She's also a fellow of the Commonwealth, and she has several awards to her credit and has more than 145 publications in peer-reviewed journal. And her clinical interest is reproductive surgery. But as her brother was admitted in the ICU, she's unable to be here. So one of her associates, Dr. Pankush Gupta, will do the presentation, and over to you, Pank. And her topic is androgen secreting ovarian tumors as a differential diagnosis of PCOS.
A very good evening, faculty members. Thank you so much for giving me this opportunity to talk in front of you. So I'll be starting the presentation. Are my slides visible?
Yeah, just put them on slideshow.
I thank again all the faculty members to give me this opportunity. So the topic for today is androgen secreting ovarian tumors. This is actually a diagnosis of exclusion. So we make a diagnosis of androgen secreting ovarian tumors only after we have ruled out everything, every other cause of hyperandrogenemia. We have all seen these diagrams in the books, the two-cell, two-gonadotropin theory, where we know that the ovaries consist of two cells producing the steroid hormones, the theca cells and the granulosa cells. Under the effect of the GnRH from the hypothalamus, there is increased secretion of the FSH and LH from the anterior pituitary, which further acts on the ovary. The FSH causes production of the acts on the granulosa cells to produce estrogens, and the LH acts on the theca cells to produce the androgens. So we know, so from here we know that ovaries are producing androgens, but not only the ovaries, as has been already been discussed by Dr. Sherville, that adrenals also produce a sizable amount of androgens. So while we are considering the hyperandrogenemia, we have the culprits are either the ovaries or the adrenals. So as seen from this diagram, we can see that the main four androgen, which is the testosterone, androstenedione, DHEA, and DHEAS. These are the main circulating hormones in our body. And DHEAS, it is very specific from the adrenals. But the rest of the three hormones, which are the testosterone, androstenedione, and DHEA, these are produced by both from adrenals and the ovary in varied percentages. So while considering the differentials, we have to consider this thing in mind. So if we see that the DHEA is highly raised, so which is specific from the adrenals, so the etiology is from the adrenals, but for the rest of the three hormones, ovarian causes also have to be ruled out. These are the diagrams showing the differences between the androgen secretion in the male and the female. As normally seen in the women, around 80% of the androgens are bound to the sex hormone binding globulin, and 19% with the albumin. Only 1% of the testosterone is free, which is required for the production of the estrogens. And in men, however, 3% of the androgens are free. But as seen in the hirsute women, around 2% of the androgens is free, which is because of the reduction in the levels of the sex hormone binding protein. But in cases of androgen secreting tumors, the overall production of the androgens is only increased, and there is no decrease in the sex hormone binding protein globulin. The topic for today was androgen secreting ovarian tumors. The ovaries, there are different kinds of ovarian tumors, the epithelial type, the germ cell tumors, and the third one, which are the main causes of concern for today, are the ovarian sex cord stromal tumors. WHO has classified these tumors into these three main broader categories, which is the pure stromal tumors, the pure sex cord tumors, and the mixed sex cord stromal tumors. But all these tumors are not the ones producing the androgens. Only few are of concern to us, which are among the pure stromal tumors, the thecomas, the steroid cell tumors, and the sclerosing stromal cell tumors are the ones which are producing the androgens. And among the pure sex cord tumors, the granulosa cell tumors and the Sertoli cell tumors produce mainly androgens. And among the mixed sex cord stromal tumors, the Sertoli Leydig cell tumors are the ones which are producing. But we have to keep this thing in mind that these causes constitute less than 0.2% of the causes of hyperandrogenism, and these are the tumors which constitute less than 1% of the ovarian tumors. So this differential comes to our mind in the very end. But also the important is to know that 75% of these tumors are seen in less than 40 years of females. So in these kind when a patient presents with these kind of tumors, fertility preservation is one issue we have to keep in mind. Coming to the pure stromal tumors, the main ones, the thecoma, steroid cell tumor, and the sclerosing cell tumor. This is a table showing the main points to keep in mind for these ones. The thecomas are mainly seen in the postmenopausal females. The steroid cell seen in the mid-20s, and the sclerosing cell tumors are seen in the second and third decade, and the mean age being 21. Most of these tumors are unilateral and are of benign nature. Only few, less than 5%, will show any malignant changes. The steroid cell tumors can be further classified into stromal luteomas, Leydig cell tumors, and steroid cell tumors not otherwise specified. The steroid cell tumors not otherwise specified are the ones which are the most common among steroid cell tumors, but the Leydig cell tumors are the ones which produce the maximum androgens. And the sclerosing tumor, stromal cell tumors are the ones which are most frequently seen during pregnancy. My slides are not moving. Coming to the pure sex cord tumors, the granulosa cell tumors, we all know that granulosa cell tumors are mainly known to produce the estrogens, but out of these, 3% of the adult granulosa cell tumors can produce androgens also. These tumors form 2 to 3% of all the ovarian tumors, and they are also of low grade to low malignant potential, and 5% of these can be bilateral. The other ones are the Sertoli cell tumors, which form 0.1% of all the ovarian tumors, and the mean age of diagnosis is 30 years. And they produce virilization in very rare cases, and these are also mostly unilateral ones. The third one, the mixed variety, the Sertoli Leydig cell tumors. These are the ones which are the most common virilizing ovarian tumors, and they 30 to 50% of these tumors produce androgens, and less than 5% of all ovarian tumors constitute these ones. And they mainly contain Leydig cells, Sertoli cells, and fibroblasts in variable proportions. They can be categorized into 4 subtypes: the well-differentiated, moderately differentiated, poorly differentiated, and the retiform types. And the mean age at diagnosis is 20 years, and they are usually unilateral, but relatively large size, and mainly limited to the ovary at the time of the diagnosis. They are mostly benign, and some may display malignant behavior. And when we encounter these tumors, we have to keep in mind that the 60% of these may have DICER1 mutation, which has been associated with thyroid tumors also. The other tumors which can produce androgens are the gonadoblastomas, which also are composed of both germ cells and the sex cord stromal cells, and they are seen mainly in the dysgenetic gonads in less than 30 years of age, and they can produce precocious puberty along with sometimes virilization, and in 40% of the cases, gonadoblastomas can be bilateral. The other androgen producing tumors can be any metastasis to the ovaries, like from the neuroendocrine tumors and other malignancies, and serous cystadenomas. The mechanism being ectopic secretion of beta HCG and just paracrine stimulation of steroidogenic cells or tumor-induced stromal hyperplasia. Apart from these, one of the very important diagnoses to keep in mind while assessing these tumors is the ovarian hypertrichosis. It is mainly a diagnosis in the postmenopausal females. It is a non-malignant ovarian disorder characterized by increased testosterone production by the luteinized Heckel cells. It is usually associated with rapid onset of hirsutism and frank virilization, and it represents mostly the second most frequent non-tumorous cause of hyperandrogenism in postmenopausal group. And the management is mainly bilateral salpingo-oophorectomy. So since now we have known that about all the tumors in brief, so how to go about the patients presenting with these tumors? First, from the pointers from the history, if the patient, when the patient is presenting to us, the age of onset, if she's a perimenopausal female, if she has rapidly progressive hyperandrogenism, or she has symptoms of virilizations like frontal balding, clitoromegaly, increased muscle mass, and deepening of voice, we have to keep in mind that she may be presenting with some kind of tumor either originating from the adrenal or the ovarian. So various tests we would like to order for these patients apart from the hormone profile, which include LH, FSH, estrogen, testosterone, DHEAS, and androstenedione, total testosterone, 17-OHP, prolactin, and TSH. Apart from these is the imaging of the ovaries and the adrenals. The various ancillary tests which can be ordered are dexamethasone suppression test, the GnRH analog test, and the ovarian and adrenal venous sampling. I'll be coming to each one in detail. The biochemical investigations Normally the testosterone values in a female are from 20 to 80 nanogram per ml, and the DHEAS levels are from 100 to 350 microgram per DL. So when a patient presenting with very high androgen levels, which is mainly testosterone, which if it is more than 200 nanogram per deciliter, and the DHEAS levels are normal or moderate or minimally high, we have to think about the ovarian tumors. But if only the DHEAS levels are raised, which if they are more than 800 microgram per deciliter, then we have to think of the adrenal cause. So we have to see the testosterone levels and the DHEAS levels in these patients. Free testosterone is the better marker to diagnose hyperandrogenemia, and it is the gold standard to diagnose free androgen testosterone is equilibrium dialysis method, but it is an expensive method and it is not readily available all throughout. But and it is most of the reports overestimate high and say higher free testosterone levels. So we are only left with the total testosterone levels. Coming to the imaging, the transvaginal ultrasound is a first-line radiological investigation for pre- and post-menopausal females. The bulky ovaries bilaterally can be seen in the ovarian hypertrichosis, but it has a very low sensitivity of around 33%. Virilizing ovarian tumors may be radiologically occult on ultrasound in up to 45% of the patients. And so ultrasound may not be very sensitive in diagnosing these tumors. The next imaging we have to our disposal is the pelvic MRI, which helps us to distinguish between virilizing ovarian tumors and ovarian hypertrichosis by identifying the unilateral ovarian nodule. And apart from that, PET scan can also be used as a diagnostic utility. But the very important thing to keep in mind that these virilizing ovarian tumors can be as small as 1 centimeter, and they can be easily missed on imaging. These are the few photographs showing the ovarian tumors, how they look like on an ultrasound. The first one showing the ovarian fibrothecoma, which has a clear boundary. It has solid and cystic echoes. There's abundant blood flow and hyper enhancement with large necrotic areas inside the lesion. The sclerosing stromal tumors, they are solid hypoechoic masses with well-defined boundaries. The adult type granulosa cell tumors, they can be solid at cystic echoes with clear boundaries and multilocular honeycomb appearance on contrast enhanced ultrasound. The Sartori Leydig cells tumors may be homogeneous solid masses with clear boundary and hypoechogenicity. As can be seen in all the ultrasounds, the most of the tumors look very similar to each other, and it is very difficult to diagnose only on the basis of an ultrasound. So MRI can be ordered in these patients. Dexamethasone suppression test can be ordered if we are suspicious of any adrenal pathology, and it has already been discussed by Dr. Sharvil. Coming to the GnRH analog test, this test is used when we suspect it's because of the ovarian hyperandrogenism, and in women where there's preferential serum testosterone elevation, and we cannot differentiate between whether it's an ovarian hypertrichosis or it is because of some virilizing ovarian tumor. So as in patients with ovarian hypertrichosis, it is under the control of hypothalamic pituitary axis. So if we give a single shot of GnRH analog, which is in the form of leuprolin or triptorelin, subcutaneous depot injection, there will be 50% reduction in the levels of testosterone by 28 days after administration of the GnRH analogs. So it suggests that it is mainly because of the benign causes of hyperandrogenism, and it is not some autonomous tumor being producing androgens in the ovaries. When we have done all the blood markers and the imaging is not suggestive of any virilizing ovarian tumors, the one thing we are left with is the venous catheterization. This method is very invasive. It does not have much role, and we do not have many patients who will require this invasive modality. But sometimes when the patient is a premenopausal female, she is requiring fertility, and we do not want to remove her ovaries. Then in those desperate situations, we may need to go for this test also. This test does the selective catheterization of the ovarian veins and the androgens are measured by taking blood samples from both the ovarian veins, and whichever vein suggests the higher levels of androgens, that ovary is supposed to be producing the androgens, and the surgical intervention is done accordingly. Coming to the management of these tumors, it depends on the menopausal status of the female. If the patient is a post-menopausal female and is and has virilizing symptoms and is worrisome about her symptoms, and we have already ruled out hyperthecosis, then and we are very much sure that she has some ovarian tumor, then depending on the stage of the tumor, we from stage 1A and 1C, we have to do a surgical staging of the tumor. In postmenopausal females, we have to do complete surgical staging along with total abdominal hysterectomy with bilateral salpingo-oophorectomy, and on the basis of surgico-pathological staging, further chemo radiation has to be decided. But in a patient who is a premenopausal, she requires a pregnancy, we have to consider fertility sparing options. If the patient is a stage 1A or stage 1C, then we can do a surgical staging, which includes peritoneal washing, exploration of the abdominal cavity, and taking biopsies, and infracoelicomentectomy and unilateral salpingo-oophorectomy, and the other ovary and the uterus can be spared, and on the basis of the surgico-pathological staging, further chemotherapy can be planned. The chemotherapy can be in the form of the bleomycin, etoposide, and the cisplatin 3 cycles, or it can be in the form of etoposide and platinum-based therapy. This current opinions in oncology, they have given this guideline in 2022 on the staging of the sex called stromal tumors, and according to them, the complete peritoneal staging of these tumors have to be done, and incomplete staging has been associated with birth survival outcomes. In patients who are undergoing fertility sparing surgery, unilateral salpingo-oophorectomy seems to be a safer option, and in patients with granulosa cell tumors, as they may be producing estrogen also, so we have to keep in mind that there may be some underlying endometrial disease. So along with surgical staging, we have to do an endometrial sampling and rule out any uterine carcinomas in patients who are over 40 years of age. The lymphadenectomy in these patients can be very well omitted and has not been shown to have any survival benefit. Regarding the mode of the surgery, laparoscopy can be easily used instead of laparotomy in these patients. So when we think of the reproductive outcomes in patients with the virilizing ovarian tumors, this was a retrospective study case series of 33 cases by Shanshu et al., where they saw out of these 33 patients, 11 patients were married and they were desirous of pregnancy, and out of these 9 cases resumed their menstrual periods after they underwent unilateral salpingo-oophorectomy, and they become pregnant naturally. So we do not need to do anything extra apart from doing surgical staging for these patients, and they can be depending on their age and the other ovarian reserve, they can be easily very well told to try naturally for conception. This is the picture from the same article. The very interesting thing to note from this is this table, where we can see that the disease course, out of these 33 patients, the diagnosis was made after 33 months to or almost 96 months. So we can see that how long these women waited to have their diagnosis, and further treatment could be given. So when we are diagnosing, when we come across these patients with hyperandrogenemia, or along with the other causes, we have to keep a high index of suspicion of virilizing ovarian tumors also in mind, and make an early diagnosis. Apart from the virilizing ovarian tumor, one entity is the pregnancy luteoma. It is a rare non-neoplastic tumor emerging in the pregnancy and regresses spontaneously after delivery. It is usually asymptomatic, and 1/3 can be hormonally active with production of androgens resulting in maternal and fetal hirsutism. It occurs mainly in the 3rd and the 4th decade, and African American population is the one which is most commonly affected. And it is mainly caused by hormone-dependent proliferation of the luteinized ovarian tumors, and virilization of mother and fetus can be seen in 25 to 30% of these cases. Virilization of the female fetus occurs in half of the patients with maternal hirsutism, and exposure between 7 to 12 years can lead to ambiguous genitalia, but after 14 years there is transient clitoromegaly. The MRI is the modality used to diagnose these conditions, but this pregnancy luteoma mainly resolves by 3 months after postpartum, and they usually reach serum testosterone usually reach normal within 2 weeks postpartum. So coming to this flow chart, which can very well help us in making a diagnosis of a hyperandrogenemic female. So first of all, we have to take a proper history and an examination of the female. We have to look for all the signs of hyperandrogenemia, the virilizing signs, any clitoromegaly, any the FG scoring has to be done. And if the patient has very rapid onset of symptoms, there are features of severe androgen excess, as has been discussed previously. She's postmenopausal and there are severe biochemical disturbances. We have to keep mainly 3 possibilities in mind. Either she has some adrenal cause, or she has some severe insulin resistance, or it is because of some ovarian origin suspected tumor. So adrenal causes we have already discussed in the previous lecture, but the diagnostic modality being imaging and treatment accordingly. For the insulin resistance, we have to send the patient to an endocrinologist. For the ovarian tumors, we have to do a GnRH analog suppression test if she's a postmenopausal female, and the ovarian hypertrichosis is one differential. And we can consider PET also if the ultrasound or MRI is not suggestive of any ovarian tumor. And if we are able to diagnose a mass on the basis of our imaging, then oophorectomy with surgical staging has to be done. But if the imaging is normal, or there are bilateral masses, and we want to preserve the ovary, and in a pre-menopausal female, in those cases we can consider ovarian vein sampling. But in a post-menopausal female, bilateral oophorectomy has to be done for these patients. Thank you.
Thank you very much, Pankaj, for that lecture. And we now move on to the next. We'll have the discussion at the end of the 3 lectures. Can you stop sharing the slides?
Yes, yeah. Ma'am. Yes, ma'am.
So we now have a second talk of the second session, and which is on premature ovarian insufficiency as a differential diagnosis of PCOS. And we have Dr. Padmarekha Jirige, who is an IVF specialist and scientific director at the Shreyas Hospital and Shushruth Assisted Conception Center at Kolhapur. She is editor-in-chief of the Journal of Human Reproductive Sciences and vice chairperson of the Maharashtra chapter of ISAR. She is the president-elect and founder member of the Fertility Preservation Society and managing committee member of the PCOS Society. Over to you, Padmarekha.
Yeah, am I audible?
Yeah. Yes.
Yeah. Good evening, everyone, and thanks. My sincere thanks to Dr. Lakshmi Shrikande, Parag, Madhuri, and Dr. Ashok Kumar for putting this very important session as masterclass together and conducting it so beautifully. So I've been asked, in the differential diagnosis of PCOS. I think all the previous speakers have elucidated how interestingly very different conditions can mimic PCOS, and I've been asked to address the issue of premature ovarian failure. So just like when we look at it superficially, it looks that these 2 conditions are diagonally divergent and opposite, and there really should not be any confusion in differentiating one from the other. Over the next few minutes, let us see whether it is as simple as that or not. So if we look at the condition of premature ovarian failure, it is a combination of amenorrhea, sex steroid deficiency, that is very low estradiol levels, and elevated levels of serum gonadotrophins in the menopausal levels before the age of 40 years. The incidence is about 1 in 100 by the age of 40 years and 1 in 1,000 at the age of 20 years. But if you look at specifically the condition of amenorrhea itself, in those with primary amenorrhea, it is as common as 1 in 4 women presenting with primary amenorrhea. And if you look at those presenting with secondary amenorrhea, it is the incidence is 4 to 18%. More recently, the term premature ovarian insufficiency has been used to encompass the whole spectrum of the condition, where from normal ovarian reserve to nearing exhaustion of the ovarian reserve occurs and finally leads to premature ovarian failure. We're all very familiar with the WHO classification of ovulatory disturbances, where ovarian failure occupies group 3. However, more recently, just about 4 months ago, FIGO ovulatory disorders classification, or HypoP, has been introduced, and it is very interesting to actually go through this. It has simplified the classification. It has encompassed all the changes and new information that has become available since the WHO classification was introduced, and it has simplified it to 4 types of ovulatory disorders. Type 1 is largely hypothalamic, type 2 is pituitary, type 3 is ovarian, and type 4 is PCOS. So the mnemonic of HypoP is arrived at. And again, under each of these conditions, there are various subsets alluding to the reason for these ovulatory disorders. And this is something which we should familiarize ourselves with. If we look at premature ovarian insufficiency or failure, we can actually see that apart from PCOS, it will fit into all the type 1 to 3 types of ovulatory disorders defined by FIGO, because the etiology is very diverse. It could be chromosomal abnormalities, specifically X chromosomal abnormalities, such as Turner syndrome or Turner mosaics, or it could be Fragile X syndrome. It could be autoimmune polyendocrinopathy, where multiple endocrine disturbances are seen. Iatrogenic causes, especially, if children have received some chemotherapy or irradiation for childhood malignancies, where the outcome and the survival is so very high, by the time they come to adolescent or adult age group, they may not have any of the details of treatment they have received. And so this is becoming an increasingly common cause of irregular menstrual cycles. And then infections, of course, varicella and tuberculosis are the most important causes. And environmental toxins, I think as specialists, none of us have started actually assessing or addressing the impact of environmental toxins, which can lead to both PCOS or premature ovarian insufficiency. This is again becoming an increasingly common cause of premature ovarian insufficiency. But can this condition truly masquerade as PCOS? We all are very familiar with the diagnostic criteria of PCOS, that is oligo or anovulation, hyperandrogenism, which is not necessarily irregular cycles, but absence of delayed or absence of ovulation. Then hyperandrogenism or hyperandrogenemia, and polycystic ovarian morphology on transvaginal ultrasonography. So if you look at the first diagnostic criterion, that is oligo or anovulatory cycles, if adolescent girls present to us with primary amenorrhea, we all know that it could just be physiological of slightly delayed puberty, or a subset of them, a large majority of them, or increasing majority of them could be those who are at risk of PCOS, or in fact, they can be having premature ovarian failure. Many of the genetic, iatrogenic, endocrine and infectious causes of premature ovarian insufficiency present as secondary amenorrhea. So many of these girls may have true menstrual cycles for some period of, or variable period of time before they develop secondary amenorrhea. And as premature ovarian failure means cessation of menses or occurrence of menopause before the age of 40, it's not menopause is not necessarily the condition we would consider as the most likely diagnosis. So that can lead to a delayed diagnosis. And we all understand fully well the challenges in obtaining true history, especially somebody who has had primary amenorrhea and consulted a family physician and has been on and off on cyclical estrogen and progesterone, most commonly that is oral contraceptive pills, and then gets married without the husband being aware of the true diagnosis, and will never actually give us the true history of having never had spontaneous menses. So it is a time consuming discussion before we can actually elicit that history. Now, coming to the second criterion of hyperandrogenism or hyperandrogenemia, very often, we do not resort to biochemical analysis to look at the androgen levels, and we usually are more likely to look at the clinical signs of acne and hirsutism, which can be present even in those who have premature ovarian insufficiency or failure but are obese and consequently hyperandrogenic, or it can happen in all adolescents as a pubertal change. It could be transient, and this can be mistaken for PCOS rather than any other cause. Now, polycystic ovarian morphology is the other criterion for diagnosis of PCOS. However, we all know that it is not mandatory to have polycystic ovarian morphology if the other two criteria have been fulfilled. In adolescents, PCOM is not even included in the diagnosis of PCOS. And when we are measuring the ovarian volume, particularly in adolescents using a transabdominal ultrasound, it may not be able to accurately assess the ovarian volume. And we may have practical issues in performing TVS in those who have never been sexually active. So ovarian morphology, for some reason or the other, may not get evaluated, and based on the clinical presence of oligoamenorrhea or oligoanovulation and some features of hyperandrogenism, these girls may get labeled as having PCOS instead of the other extreme of premature ovarian failure. Many of them may also have some signs of insulin resistance, which we almost correlate with the diagnosis of PCOS, even though they're not diagnostic criteria in themselves. That is presence of insulin resistance and its features like skin tags and acanthosis nigricans, because some of the women with premature ovarian insufficiency or failure may be in that syndromic group of having multiple endocrine pathologies, and again they may be mislabeled as having PCOS rather than POI. What about actually performing some endocrine evaluation? Does it reduce the confusion? Of course, we know that in many of the girls or women with PCOS may have high basal levels of greater than 10 international units, whereas on the other hand, those who have premature ovarian insufficiency will show progressive increase in FSH and LH. But we have to remember that nearly 20% of healthy women may have abnormally elevated FSH without having any clinical significance. But what is important is if somebody has an FSH and LH of over 40 international units per liter, that is unlikely to be just elevated LH because of PCOS, and it is most likely to be premature ovarian failure. Even here, there can be confusion if they have been on oral contraceptive pills for a very long period. That can give a spuriously normal FSH and LH levels, and we have to be aware of this. What about anti-Mullerian hormone? We know that anti-Mullerian hormone is considered as a surrogate diagnostic marker for PCOS, even though it has not been officially included in any of the diagnostic criteria. Most of us would look at AMH levels to see whether they are indeed having PCOS. And we know AMH is the reflection of the functional follicular pool, because it is, we can never measure the primordial follicular pool, the size of primordial follicular pool, which reflects the total ovarian reserve. We still do not have any means to measure that. However, the functional ovarian reserve, or the functional ovarian follicular pool, that is the number of follicles which are getting recruited, can be measured by the AMH, and it is a very sensitive, hence it's a very sensitive marker of ovarian reserve. There are certain caveats when we use AMH to look at whether the ovaries indeed have adequate number of follicles or not. It is before 25 years of age, it can be on the lower side despite having normal follicular size of follicular pool, and it peaks at 25 years, and beyond which it progressively decreases. So if we look for AMH values in somebody younger than 25 years, we need to be aware of this. If they have slightly lower AMH levels, it may not reflect a very low ovarian reserve. What is important, one of the issues that complicates the interpretation of AMH levels is the ethnicity and its impact. And I think now we know that Indian women do have nearly 20% less ovarian reserve at any given age compared to their Caucasian counterparts. And this is something which we have also established recently in a large cohort of more than 1,600 women. And here, if we see, one of the issues that arise even in women with PCOS is, as they go beyond 35 years of age, their AMH levels may not be reflective of the diagnosis of PCOS. And in fact, it may be progressively declining, especially if they've been on metformin, they've undergone ovarian drilling and various such interventions. However, even in Indian women, this peaking at 25 years phenomenon is seen. So that is something very important to bear in mind if we are looking at ovarian reserve in younger women, adolescent women, adolescent girls, and women below 25 years of age. So when we are using AMH to try and differentiate between PCOS and premature ovarian insufficiency, we have to know that AMH is high in PCOS women. Usually for Indians, it is considered as above 3.6 nanograms per ml. It is very low in those with premature ovarian insufficiency. If we detect a value of 0.43 or less, they're to be diagnosed as premature ovarian insufficiency if they're below 40 years of age. And failure, premature ovarian failure in those below 40 years of age, if the level is less than 0.0 nanogram per ml. Or if we do have a population normogram, for India, we do not have a normogram yet. For those population where the population normogram is present, if the AMH level is below 5th centile for that any given age group, then it is considered as premature ovarian insufficiency. However, even in those who have normal AMH levels, if they have been on oral contraceptive pills, the levels can be as low as 55% than what actually it is. So this is another thing we need to be wary of. So I think we all we have to go back to the usual algorithm we use to establish any diagnosis, taking history and establishing whether it is primary amenorrhea or secondary amenorrhea, which is masked by use of cyclical hormonal therapy, is something we need to establish. Clinical examination in those who have never received any hormonal therapy and are presenting with a premature ovarian failure in their teens, examination, short stature, lack of development or poor development of secondary sexual characters may all indicate some genetic reason behind the diagnosis rather than PCOS. And endocrine evaluation when they are not on any hormonal replacement, preferably for at least 6 weeks, and where indicated, TVS and looking at polycystic ovarian morphology may help. Is it really important to establish this diagnosis as early as possible? May not be so for most of the women, but those who are Turner mosaics and those who have very low ovarian reserve at a young age, those who have premature ovarian insufficiency but not premature ovarian failure, this may have some very important clinical implications, as they may have some amount of ovarian reserve. With timely diagnosis, fertility preservation may be feasible in this small subset of women, either as oocyte cryopreservation or ovarian tissue cryopreservation. And in future, use of recombinant AMH may be considered in these subset of women to prevent early exhaustion of follicular pool by preventing their recruitment into the growing pool. So why is this differentiating necessary? Both diagnoses have very different reproductive and metabolic implications, as we all understand. A diagnosis of premature ovarian failure implies that these girls eventually will need to go for oocyte donation to have any realistic chances of pregnancy. Also, throughout their young age, they may have consequences of very low estradiol in the form of skin issues, dyspareunia, bone health issues, and cardiac health issues. And hence, the counseling is very different depending on the diagnosis of PCOS or premature ovarian failure. So indeed, premature ovarian failure and premature ovarian insufficiency can be mistaken as PCOS, and an algorithmic approach as an initial step is necessary to differentiate between the two conditions. This is of utmost importance for appropriate counseling and individualized management later on. Thank you.
Thank you very much, Rekha, for that excellent talk. And we'll have the questions at the end of the session. And we go to the, can we just stop sharing the slides so that?
Yeah.
Yeah, so we now have for the last talk of the session, and that is on uterine abnormalities as a differential diagnosis of polycystic ovary. So we have none other than Dr. Krishna Kumar, who's going to talk to us on. He's a chief consultant at the JK Women's Hospital and Fortis Hospital. He's an excellent endoscopic surgeon. He's the immediate past president of the Indian Association of Gynecological Endoscopists. He's also an ASHRAE certified reproductive endoscopic surgeon. And he's a recognized teacher for ICOG fellowships. And he's also the recipient of the National IMA Award 2019-20 as an eminent medical man for distinguished achievement of highest order. So over to you, Dr. Krishna Kumar.
Please unmute.
Okay, fine. Thank you. Thank you, Dr. Lakshmi Srikande, the chairperson of the ICOG, and of course, the convener of today's program, Dr. Madhuri Patil, for having me in this very, very interesting topic on PCOS as an exclusion criteria for the various aspects of PCOS have been discussed in these last 1.5 to 2 hours. And my talk has been something related to PCOS, but at the same time, people will wonder the association between uterine anomaly and PCOS, and of course, how to exclude uterine anomaly in a patient who comes with PCOS, where you're suspecting, and I think all these aspects of right from tumors, thyroid, hypothyroid have been discussed wonderfully, and thanks for the nice introduction. Of course, PCOS, I think you have all discussed extensively. We know that the prevalence rate is about 5 to 10%, and the pathophysiology of PCOS definitely is multifactorial. I'm sure you all have been given a great idea about the same, and being a polygenic. And of course, most of them do have menstrual irregularities in the form of either amenorrhea or oligomenorrhea. But the main feature we all know is, apart from hyperandrogenism and BMI, these are, I wouldn't go into the diagnostic criteria, which I think has all been discussed extensively. Well, the reproductive features in PCOS, we know that because of the anovulation or ovulation, the infertility problem is very much part of the treatment and part of the presentation. Major cases of anovulatory infertility is PCOS, but we know that PCO patients have an increased risk of miscarriage and pregnancy complication as GDM and preterm delivery. Now you will wonder why I'm introducing this. Well, if you look at the congenital uterine anomaly or uterine anomalies which could come, it's a result of the Mullerian duct malformation, canalization defect, and it's basically because of the failure of resorption of the midline vaginouterine septum. But it presents a lot of diagnostic challenge because of the various ways it presents. Well, the prevalence of uterine malformation, basically the congenital uterine malformation in general population is reported around 6%, whereas those patients with recurrent miscarriage, it is anywhere between 12 to 18%. And we know that it is because of the abnormal formation, differentiation, and fusion defect of the paramesonephric duct during the embryonic stage. Well, the Mullerian duct anomalies are most typically noted de novo and without significant hereditary distinction, and familial aggregates of such conditions have rarely been reported. Well, on the contrary, we know that PCO has a lot of genetic and familial hereditary reasons. Well, the most common presentation of uterine anomaly is mainly, of course, with obstetric related. But in a young girl, when they present, when they're still not married, they do have certain presentation which might be confused with PCO because of the amenorrhea, which is the classic symptom of some of the genital tract problems, or oligomenorrhea. And you may occasionally catch up with the Mullerian anomalies in patients who do present with symptom of PCO, basically oligo or amenorrhea. Well, there are various classification of uterine anomaly. I wouldn't go into. The most common or the famous one has been the ISRA classification. And recently in 21, basically, if you look at the ASRM classification, they have included a lot of other things which can be reason for aplasia of the cervix or the ischemo-cervical aplasia. And apart from the uterine absence or a Mullerian agenesis, the cervical agenesis, and we will look into the transverse vaginal septum, which could be either in the mid part of the vagina or the distal vaginal part. I wouldn't go into the detail of this classification because of, I think this is all available readily, but these Mullerian agenesis and cervical agenesis or the transverse vaginal septum can present as amenorrhea in a patient, young patient, where PCO could be suspected. But we know that the association between reproductive outcome and uterine anomaly is now well established. And in some cases like septum, the conception rate is there, but then basically most of them are obstetrically related. So patients with PCO do have similar second trimester miscarriages and other miscarriages. So what is the correlation between PCO and congenital uterine anomalies? If we look at the embryonic origin of the ovary and the uterus, they have different. So thus, for a patient with Mullerian anomalies, we would expect an undisturbed ovarian function. But does that exist, or is it a reality? The answer is definitely no. It has been proven that patients with PCO have definitely certain uterine anomalies, and it has been confirmed very early by Ugur et al. Way back in 1995. And PCOS and certain type of Mullerian anomalies may reflect a different or a defect that shares a common etiopathogenesis. So are we looking at something which could be somewhere related? Though we do not have conclusive evidence, we know that the earliest, as I said, this is a publication from the European Journal of Obstetrics and Gynecology, where same Ogur et al. In a big study did say that frequency of PCO in patients with Mullerian anomalies. Almost 14% had hypoplasia or agenesis of the genital tract. So this was the earliest studies. Of course, the incidence of septate and arcuate uterus seems to be much high, but other anomalies also were reported in this large study. So definitely made the association between uterine anomalies and PCO may reflect a certain developmental defect that do share a common etiopathogenesis. So, of course, further studies are required, and this was the famous Konuta study, where a retrospective cohort study was taken in patients with PCO, and there, as per the ASRM ESG classification, what they found was this classical finding, which you can see, that partial septate uterus was reported in patients with almost 21%, whereas only control group at about 6%. Even septate uterus, the other dysmorphic uterus or the T-shaped uterus, all were definitely high as per this Konuta study. So this is a very famous study which gave a big correlation between them. But this is one of the recent studies, again by Isham Ali and Fadi Shauki, where they have given a very, very high incidence of PCO with arcuate uterus and definitely septate or subseptate uterus, not so much with the other anomalies. So definitely PCO and CO have similar obstetric implications as far as miscarriage and the poor reproductive outcome. So could there be a possible association between them? Whereas even this study by prevalence of cervical insufficiency and various other research have been definitely shown that the connective tissue in the cervixes have been abnormal in patients with Mullerian anomalies, definitely when it is also with PCOS. So we need to look at this. Is of course not totally for diagnosis of PCO, but this is the obstetric implication. So AMH, which is supposed to be high in polycystic ovarian disease, whether higher levels of AMH in patients with PCO could be thought as a predisposing factor rather than a result. This could be linked to the coexistence of uterine anomalies, knowing that the definite role played by AMH during embryonic life for Mullerian duct abnormality. So whether patients with AMH, high AMH, which is known in PCO, so those embryos which have been subjected to high AMH, maternal high AMH and androgens, whether the abnormal uterine malformations have been correlated. So this is again proven by, of course not yet proven, but this was a study conducted by Paulos et al. The common features which we look today at polycystic ovarian disease and uterine anomalies are, of course, we come back to the classic symptom of PCO, which is amenorrhea, oligomenorrhea, and of course not the direct feature, but poor obstetric outcome. So when you look at uterine anomalies with oligomenorrhea, if you have a non-obstructive, the MRKH syndrome, Martin-Rokitansky-Turner-Russell syndrome. If it is obstructive, it could be cervical aplasia, partial vaginal aplasia, or complete vaginal septum, imperforate hymen. So a patient, woman, a girl, early stage age, when she just presents with amenorrhea, these, if you are looking at the uterine anomaly, in a patient with PCO, these are some of the common conditions which one has to look, or in your diagnostic modality, how to differentiate, how to diagnose is going to be the main answer. So patient with primary amenorrhea, we know that gonadoid dysgenesis is the leading cause, but MRKS or the Mayer-Rokitansky syndrome could be almost in about 14 to 15%. It's the second leading cause of primary amenorrhea. So Mullerian anomalies has to be thought of any patient who comes with primary amenorrhea. And transverse vaginal septum, usually these patients will have other obstructive symptom in the form of spasmodic periodic pain and could be having other pressure symptom could be related with the adjoining structures. Well, MRKH, just to touch upon it, it's a normal female 46 karyotype. The incidence is about 1 in 5,000. And as I said, it is the second most common cause of primary amenorrhea and after gonadal dysgenesis. Well, this very nice study, which I just came across in the prevalence of acne in patients with MRKH syndrome in reproductive bioendocrine, where they found that in the study of about 69 women with MRKH syndrome, they had biochemical hyperandrogenemia. I mean, the androgen was high, but the clinical signs of androgen excess was seen in much less patients. That means the classic finding of acne and other hyperandrogenic features are less in patients with MRKH. So it is something which very interesting that patients with MRKH though may have PCOS, but the hyperandrogenic features have been less, especially the acne. Now this is a part of the obstructive symptom which you can see how a patient, just to show the video of a patient with ovarian syndrome where patient presented with pain and amenorrhea. You can see classic obstruction in the vagina where you can see the bulge, obstructed hemivagina, bulge of the hematocolpus is seen. So bipolar saline resectoscope you use to open it up and cut it so that you drain the hematocolpus and the hematometra in this patient. So these are one just video where obstructive symptoms, basically the vaginal septum, could be a reason for amenorrhea, but then picking up all these cases are going to be more simple because of the pain which is periodic, and of course your sonography itself will diagnose about the presence of hematocolpus and the hematometra, and you can see the drainage has reduced the size, though there is a rudimentary on the other side. You can see the corresponding side hematosalpinx, which was just drained and left, and the patient definitely had symptom relief immediately from next cycle. Well, another condition which can present as amenorrhea or oligomenorrhea is Asherman, and Asherman has been the most common condition where, of course, it is basically an iatrogenic condition caused by our surgery. Basically, DNC was the old culprit, but today with hysteroscopy it is increasing. But de novo amenorrhea or adhesions in any woman is basically, in our country, is chronic endometritis, mainly mostly due to FOGS. It has a genetic predisposition. It has been noted more with patients who have septate uterus. Well, this one study where Mullerian by Stillman et al., they proved that Mullerian duct anomalies patients have a higher incidence of Asherman, and one case report suggests that even schistosomiasis may cause a granulomatous reaction to the endometrium and fibrosis, ultimately adhesions and amenorrhea. So these are some of the interesting cases which can be. So of course, this is just a case of a primary amenorrhea because of FOGS, where you can see how hysteroscopically one can create a cavity. So this is an Asherman. This is just to show something more than theory. I thought of showing this video where you can see there is total paleness of the cervical mucosal glands, flattening in a patient with primary amenorrhea, proved FOGS, no endometrium. So we are just trying to create a cavity. So this is just to show how in a grade 4 Asherman or totally proven FOGS case, also you can create that cavity and hope for the endometrium to grow. So this patient who had total primary amenorrhea, after this procedure, started menstruating, though definitely not, but at least 2 sanitary napkins for 2 days. So that itself was a significant achievement for her. So this is one such interesting case where a patient had tuberculosis. You can see the total uterine cavity being obliterated, and you can see the tissues being so pale and fibrotic, and hardly, and rather no endometrium, I would say, is detected. But creating the cavity was the primary idea. The cavity, which is triangle in shape, adequate in size, you can see at the end of the day, you can identify this is a FOGS endometritis because of the paleness, because of the caseous material like zinc, which you can see. But as you can see, once the cavity is created, this patient started menstruating, and on a second look hysteroscopy, little bit of more endometrium was definitely seen. So that is the idea of showing this hysteroscopic surgery in a patient with primary amenorrhea because of FOGS. Of course, the assessment of PCO and uterine anomaly, you can, every patient, we are going to subject them to a good transvaginal or even, of course, abdominal sonography if the patient is single. And you can definitely 2D or 3D sonography is the order of the day where you can pick up PCOS. And of course, most of the uterine anomalies, though MRI is considered the gold standard technique for diagnosing uterine anomalies. So some patients who have difficulty in diagnosis with primary amenorrhea, even if there is PCO, one should subject them if there is suspicion of some of the uterine anomalies, especially MRKs, which cannot be picked up occasionally by a good 3D sonography. So the direct comparison between this, and this is one of the study where a 19-year-old girl with primary amenorrhea, you can see that the uterus and vagina is absent. The ovary is seen on this side, the normal looking ovary. So these are some of the diagnostic modalities which one should use. So in conclusion, anomalies in PCOS, several studies have proved a moderately significant association between PCOS and uterine anomalies. So patient with PCOS should preferably checked or investigated for uterine anomaly or vice versa. So this has been definitely proven with many, many studies. Thank you for the patient hearing.
Thank you very much, Dr. Krishna Kumar, for that excellent talk. And I think all the three talks were great. So the first talk basically, which was on ovarian, androgen secreting ovarian tumor, just one algorithm if we keep in mind is where we are suspecting, and especially it should be suspected when there's a lot of virilism, and we do the testosterone levels. If they're more than 200, we do the DHES levels. If they are more, we know it's adrenal. If they are less, we know it's probably an ovarian tumor. If it's less than 100 or 150, then we should do the ACTH test. And we also should look at the 17-hydroxyprogesterone levels. If they are high, we know that it's a non-classical form of hydroxylase deficiency. And if it is low, basically, we know that it could be PCOS syndrome. The second talk was also excellent. And Dr. Padmarekha Jirge very well described the different why POI should be the differential diagnosis of PCOS. And she also introduced us to the new FIGO classification of menstrual irregularities, which is totally new. And I think everybody should take a note of that. And Dr. Krishna Kumar very well described the various anomalies of the uterus, which can be misdiagnosed as it could be one of the differential diagnoses of PCOS, wherein we are suspecting PCOS, but the patient has some uterine anomaly. So I think there's one question, and that is a patient who's 40 years, having 4 months amenorrhea with small ovaries, normal TSH, normal prolactin and FSH is 3.5. What should we do? Endometrial thickness 7 millimeters and 3 centimeters ovarian cyst. Padmarekha.
Yeah, I think one of the missing information here is her AMH levels. I mean, somebody who has had assumingly regular cycles up to 40 years of age and then becoming amenorrheic, it is very unlikely that she has PCOS. So I think the first step would be to look at her AMH levels, which should tell us whether there is any ovarian reason for this amenorrhea.
Yeah, so there's another question. A 22-year-old unmarried girl with acne with regular cycles with FSH of 1.2 and LH was also 1.2. AMH is 8.4. Will there be a scenario like this?
I think conventionally with FSH and LH, less than 2, we would consider, it is very likely to be hypogonadotrophic hypogonadism. So I think we'll need to see whether she has been on any oral contraceptive pills recently. And also in hypog, the AMH level usually is within low normal or normal range. We don't usually get a high AMH level. So this is a situation where I would first look at whether the tests have been done in the early follicular phase and what assays have been used for looking at AMH levels. And if she's having regular cycles and if she doesn't have, apart from acne, if that is concerning, then, very likely that we'll have to look at the hyperandrogenemia profile, whether she has any, we need to look at the androgen profile. And if that all sort of correlates to possibility of PCOS, then I think FSH and LH probably, there is some, like assay related issue or the time related issue.
Yeah. So, many a times, even in a PCOS, we could have normal FSH and LH levels. So, I think that also we should.
Normal, it is okay. It doesn't have to be, LH doesn't have to be abnormally high.
Abnormal. Yeah, that's what we could have a normal. And therefore, today, nowadays, we really don't consider LH as one of the diagnostic criteria of PCOS diagnosis anymore. Any more questions? If a woman is on OCPs for 5 to 6 years, her AMH turns out to be 0.8. After how many months AMH is retested? 3. It's usually retested after 3 months.
But it would also depend on what her age is and what is her fertility intentions to attach, whether we should attach any importance to AMH or not. But definitely, as you say, after 3 months, but definitely not before 6 weeks.
Yeah, it takes almost that much time. Any more questions? So if there are no more questions, I'll just conclude the session. So we know that PCOS is not just skin deep, and the diagnosis should be one of exclusion, and we have to exclude. So basically, pregnancy is also one of the things which we need to exclude by beta-HCG, premature ovarian insufficiency by doing FSH and AMH, hypothyroidism by doing TSH, hyperprolactinemia by prolactin, congenital adrenal hyperplasia. If you suspect, you have to do the 17-hydroxyprogesterone. And in patients with ovarian tumors, the total testosterone is important, especially if it is more than 200. In adrenal tumors, DHES is high and it's usually more than 800. And in Cushing's syndrome, one must do a serum cortisol level. Whereas when it comes to uterine abnormalities, MRK syndrome, intrauterine adhesions, and the other aspects which Dr. Krishna Kumar is very well described. And thus, PCOS is a diagnosis of exclusion. And we have to also screen these patients for long-term issues wherein you need to look at the lipid levels and the glucose levels. And many a times, we know that they have an increased incidence of endometrial carcinoma, so an endometrial biopsy. And they have sleep disorders as well as depression, and therefore, they need to be screened for that. Therefore, we have to look beyond just PCOS because there's lots that could be there. And therefore, though we know that it's the most common endocrine disorder, and these patients can come either to the obstetrician or to the dermatologist or even to a general practitioner or to an endocrinologist. We have, all of us need to establish the diagnosis before we treat them. And we know at times the radiologists just do a scan and they give a diagnosis of PCOS, but they forget that there could be other abnormalities. And one has to look at the multiple phenotypes that is, which are present, which include androgen excess, ovulatory dysfunction, and the polycystic ovaries. And basically because of multiple differential, making a diagnosis may be challenging, and monitoring for cardiovascular and diabetic complications and reproductive cancer is a key part of the management. So before I thank you all, I would like Dr. Lakshmi Shrikande to say a few words.
Madhuri, because really I'm speechless. I mean, PCO is a diagnosis of exclusion. The way you chose your topics and speakers, I learned a lot. So I'm sure all the delegates who attended, they must have been benefited by this wonderful masterclass, which you have been the convener, and this is your brainchild. And from Team ICOG, thank you so much to you for conceptualizing this masterclass on PCOS and executing it so well. So thank you, Madhuri.
Yeah. Thank you. Thank you to all the faculty for spending the afternoon with us. And I thank Dr. Lakshmi for giving me this opportunity to be a convener for this masterclass. Thank you all very much. And I thank all the attendees, and I'm sure y'all would have had a lot of take-home messages and who have stayed right till the end, because we had more than 250, but now we are having less. So I'm sure all of y'all would have benefited with this webinar. And I thank all the faculty once again. I thank Dr. Sharvil Gadwil, Pratap Kumar, Dr. Krishna Kumar, Padma Rekha Jirge, as well as Dr. Gupta, who replaced Dr. Neena Malhotra because she had a medical emergency. And thank you, ICOG team, as well as Dr. Lakshmi. Thank you all.
Next month, we are having masterclass on obstetric topic. So don't forget to log in.
So it will be on every second Friday
yes,
of the month, and it will be between 4 to 7 p.m. as we had it today. So and then the third one would be on gynac, and then again we would repeat as infertility, obstetrics, and gynecology. Thank you all.
Thank you. Komal, you can stop recording.
Yes, ma'am.
Thank you.
Thank you, sir, for making it.
Thank you. Thank you.
I know you are the boss, you can.
Pleasure.
He said, Madhuri